Good morning, everyone. Welcome to the 14th annual California ACC CVT Symposium, and it's also our first annual joined Northern and Southern California Symposium and our very first virtual symposium. Thank you for taking the time and joining us, and we hope you enjoy as much as we have in planning this meeting for us. I would like to share some information. The California ACC Cardiovascular Team Annual Symposium is starting today, and our mission is to empower members to provide transformative cardiovascular care leading to improved heart health for Californians. The California team is the largest chapter in the United States, comprising of nearly 3,000 physicians, 330 fellows in training, 686 cardiac care team members, including 35 who are AACC designates, 62 practice administrators, and 146 residents and students. This is who we are in our work settings. Almost 30% are in cardiovascular groups, 12.5% are in med school universities, about 13.6% retired, approximately 5% are in non-government hospitals, and 23.8% did not list where they work or have not figured out where they are. Just kidding. And in the clinical focus, approximately 50% are in adult cardiology, 16% are in interventional cardiology, and the rest of the breakdowns are listed. Oops. And I am Mary Hunsinger. I'm the Southern California rep, and Jonathan David is my Northern California rep from Stanford. And I would like to introduce my team, the education work group, and that would be Michelle Toussaint, Jonathan David from Stanford, Simona Campa, my colleague in crime from Cedars-Sinai, and Evelyn Taverna, past Regional 1 rep and director. And of course, Liana Kalange, who is our Region 1 and California Executive Director of ACC. And on behalf of the entire planning committee and work group, we welcome you to our meeting today and hope you enjoy as much as we do. Now I'm going to turn this over to Jonathan David, who's going to help moderate the symposium.
Thank you, Mary. Good morning to everyone. I'm excited for today, and I hope you're all too. I would want to make sure that you use your links for your pre-test and post-test. You'll get the email notifications. If you have any questions, please post them in the chat. Michelle is able to take those questions and bring those questions back to the speaker. So with that, I'm going to go on to the first topic. I would like to introduce the first topic as lipid management update. As we know, atherosclerotic disease is a leading cause of death worldwide. Despite clinical long-term or short-term benefits of lowering cholesterol, especially in primary and secondary prevention, it remains untreated. We know many times there are folks in quality say, these are before discharge. We want to make sure a patient goes on statin therapy, and still it's challenging. And so this, not many patients who need this are receiving it. So this presentation is going to review the updates on lipid management, the different classes of treatment, and their clinical uses. With that, I'm going to introduce the speaker, Viet Lee, who is a physician assistant from Intermountain Heart Institute. Viet is an associate professor of research at Intermountain Healthcare. He's the current president of the Association of Physician Assistants in Cardiology and co-chair of ACC PA Committee. Since 2012, he has held this position as cardiovascular research scientist with Intermountain Heart Institute Cardiovascular Research, and is a current principal investigator on omega-3 research. He's also the past and present co- and sub-investigator on other industry-sponsored lipid research, has presented data at multiple national scientific conferences. He's been the first author and a co-author on multiple publications in the area of lipid science. Yeah, he's a very busy guy, but I could say he's also, I think he's not busy enough, so he added the doctorate in medical science, which he's pursuing at the moment. So I cannot wait for Viet to begin speaking. Viet, I'm going to hand over this to you.
Great, thank you. And I'll go ahead and share my screen here. So hopefully, I'm sorry, that makes me feel a little bit more professional than I feel. But I hope to take you through this with lipid management, evaluation, treatment, and some updates here. But mostly what I want to do is bring us all up to 2018 with the guidelines that were released just 3 years ago. As you know, it takes a little bit of time, and we have some guideline inertia that occurs. And ESC Congress has just come through with several more updates to their guidelines. So I want us to at least be on a level footing. So as we go through this, then I run an advanced lipid cardiovascular prevention clinic. We call it ALCAP with my colleague Jeffrey Anderson, and then Haley Maria. We have genetic counselors because we do see a lot of familial hypercholesterolemia, and I'll hopefully describe to you how important it is to evaluate and identify that. So conflicts of interest, as has been mentioned, I am co and sub-investigator on multiple sponsored lipid trials, but really any honoraria that I've ever received once was for a symposium, and that was sent to my research department. So the objectives today, again, I want to kind of level us all up. We'll review the AHA 2018 guidelines for the treatment of hyperlipidemia, look at the cohorts, because I think that's something that a lot of folks aren't quite sure of, is who should we start statins and lipid-lowering therapy. We'll practice this implementation of the guidelines, then we'll hopefully understand whether you should stop it or continue statins past the age of 75. Just recognize that almost all of our research clinical trials really included patients from 40 to 75. And that's why we have this lack of data beyond the age of 75. Now, we do have a trial right now called Preventable that is looking in that area, the age of greater than 75, in a real world setting. And then we'll review that prevalence, impact, and importance of early identification for heterozygous familial hypercholesterolemia. All right, so let me help you for this talk. If you haven't had a chance yet to use these, really get yourself familiar with the ACC CVT Risk Estimator. And then if you've not used the CardioSmart Heart Explorer app, just follow my Twitter and you'll find that I like to use CardioSmart Heart Explorer. If there's a real quick way to get past the problems of, we say 5th grade, 8th grade written language for patients and education, but that still doesn't matter if a patient doesn't know what coronary artery means. You can't really make that any less scientific than it is or medical than it is, but showing them the pictures of what a coronary artery is, what atherosclerosis is, where the heart sits in the body is really key to education if you are thinking about shared decision making, which APPs, PharmDs, all of us do a really great job at, but this will level you up. Okay, guidelines. We've evolved. I think I love this. You're moving upwards, and then have we evolved, actually? It's a difficult area because even in 2018, when the most recent ACC AHA guidelines were released, Reduce It came out, and that was icosapent ethyl. There was no space for omega-3 or EPA inside there. And I think what happens is guidelines take 2 to 3 years to develop. And in that space of time, clinical trials are constantly moving forward. I refer you to this. Erin Mikos is a great friend of mine, and she's first author here on this New England Journal of Medicine paper on lipid management. So, the citation's down below. But let me run you through this. It looks, for those of you old enough, it looks like Alien, right? This big liver head. But here, look for, let me see if I can make a laser pointer. Here we go. So here's dietary fats as they come in. And, think of the liver off to this side. This is graphically a big artery anywhere in the body. And we're trying to consume this dietary fat into our colon through the villi here, and especially through this NPC1L1 receptor. But fats come in and then they're emulsified by these bile acids that leave the liver into the gut, and they form these micelles. Then those micelles are brought in through the NPC1L1. That'll become important because that's where ezetimibe sits, to become these chylomicrons. And then from chylomicrons, they pop into this arterial wall and are into circulation, but lipoprotein lipase begins to hydrolyze these. So these remnants drop off and they can be used immediately into muscle for energy, or they can be stored into adipose. And as they continue to break apart, now they're in a consumable enough protein that, or fat, apolipoprotein, that can be brought in by ApoE. And that starts this process here of becoming cholesterol. Okay, and here's HMG-CoA. If you've heard of bempedoic acid, well, this is that cascade that you'll become familiar with as we move forward. And then lastly, ApoB, as it sticks onto cholesterol, will now allow it to become VLDL. And then, that VLDL will break down further into LP by lipoprotein lipase into intermediate density lipoproteins and LDL. So VLDL, IDL, LDL really are all the same big structure that continues to break down, but they all have ApoB. So if you've ever heard of ApoB and why we should order an ApoB rather than LDL cholesterol, it's because all of them have ApoB on them. Okay. So coming back to the 2018 management of blood cholesterol, it just breaks down into primary or secondary. That's it. I mean, those are the kind of big roads that we think of traveling here. And those cohorts fall into, primary and secondary risk for statin eligibility. This is it. So anything green are those that you think about for either starting a statin or saying, well, your risk is low enough, we don't necessarily worry about you. But here on the primary risk side, you have diabetes 1 and 2, 40 to 75-year-olds that do not have diabetes and have not had an event such as MI, stroke, or PAD, and then those that have LDL cholesterol greater than or equal to 190, regardless of whether diabetes exists or what their age is. And then the secondary risk. Well, secondary risk is probably the easiest to take care of because if someone's had a heart attack or a stroke, or they've been diagnosed with peripheral arterial disease if you're looking for it. Okay, so this is slightly busy in the sense of all the other categories within those, but just know that those four cohorts fall here. And so let's look over on that secondary risk side. Let me first introduce you into this idea of moderate, high, and low intensity statin therapies. I like to call high intensity statin therapy HIST. So it reduces LDL cholesterol by at least 50% or more. And really, there's just two statins, atorvastatin 40 and 80, rosuvastatin 20 and 40, right? Atorva and rosuva, and then those doses. Otherwise, moderate intensity 30 to 49%, and low intensity less than 30%. So once we move to these next slides, you'll understand why high intensity is very easy to think about and implement almost always. Okay, so why do we do this? I mean, why do we even think about initiating statin therapies? Well, this slide here will give you a sense that when we looked at the 4S trial, okay, this is way back now in the 80s, and they were looking at statin versus no statin. For every 38 milligrams per deciliter LDL reduction, you have a drop of 20% in MACE. MI, stroke, PAD in the first year. But as you continue that statin, why wouldn't you? They would have an additional kind of long-term 25% risk reduction, okay? But look at the 4S trial. The inclusion was 190 milligrams per deciliter. One would argue that most of these were probably familial hypercholesterolemia patients that were enrolled in this trial. But this is no statin, versus what happens when you add a statin. You can get them down to 115, but look at the reduction from 26% plus event rate down to less than 20%. Now that's not the best, right? But we're looking at a group of people that were enrolled at 190 milligrams per deciliter. So in more statin versus less statin intensive therapies. So we're now looking at treating to new targets where they were already on a 10 milligram atorvastatin, and then we dropped them further to 80. Their baseline was already lower than 4S at 95, and then you dropped them just above 70, you still get an additional reduction in MACE. This is, 19 milligrams per deciliter drop equals 15% further reduction in MACE. So the bottom line is, if you can initiate a high intensity statin, which reduces at least 50 milligrams per deciliter or greater than 50% from baseline, there's nearly a 30% reduction in risk. So it's important to think about it from that perspective. That's why we initiate at high intensity statins. That's why you hear lower is better and statin versus no statin and more intensive statin therapies. So secondary prevention, here we are. The acute coronary syndrome, MIs, so the heart, ischemic strokes, and then peripheral arterial disease. This is what we discuss when we think about secondary prevention. So the first minimum goal, let's just make it easy. The first minimum goal is to add the statin and a greater than or equal to 50% LDL reduction from baseline. You're thinking, okay, that's pretty easy. That's high intensity statin, HIST, Torva 40 or 80, Rasuva 20 or 40. And the nice thing is that it doesn't take a lot of thought to add one of those two medications at those doses for secondary prevention. Just know that it led to a lot of people thinking, well, I just set and forget, or fire and forget is what they called it. But really, that's the first minimum goal. Then the AHA 2018 expanded goal is really when you have very high risk individuals, you want to go for an LDL target of less than 70 or a non-HDL-C of less than 100. And so if you started a high intensity statin, but they're still sitting above 70, then add ezetimibe or PCSK9 inhibitor. So that was really it. I mean, that's kind of in a nutshell, the easiness of it. Of course, precision medicine means that the patient in front of you is a little bit different and reacts differently to the medications. But these are the first thing, greater than or equal to 50% reduction, and then shoot for less than 70. So the cohorts for statin eligibility, let's look at the secondary risk. Okay, how does it shake out? Well, there's two different categories under secondary. Either someone that's stable, it's been a while since they've had an event, but they've had an event, or very high risk is within the past 12 months, they've had an acute coronary syndrome, or it's been a couple of years, and then they had a second event, or they have major risk factors, multiple comorbid conditions. So we'll review that. Here's the stable ASCVD, always HIST, high intensity statin therapy. The nuances though, is that if they can't tolerate high intensity statin therapy, I don't mandate, I'm not militant about this. Patients, you have to work within their goals and what they're experiencing. And there's statin myalgias. So if they can't tolerate high intensity, at least keep them on something, and moderate intensity statin therapy works. If they're greater than 75, this reaches that idea of, oh man, the clinical trials didn't really enroll anyone over 75. So in the paucity of that evidence, we think of greater than or equal to 75. Well, you can start MIST if it's their first event, or if they've already, they were 74, they had their event and they reached 75. If they tolerated high intensity, keep them on high intensity. But consider ezetimibe if their LDL is greater than 70 milligrams per deciliter. So that's a class 2B. You just consider it. Whereas within very high risk individuals, you should start them on high intensity statin therapy. Now, why the difference here, HIST or max statin tolerated? Because the trials were created that way. Fourier, Odyssey, those were the PCSK9 trials. They basically added in language that said, well, if you can't do HIST, then any tolerated statin, including zero, statin intolerant, that was their max statin intolerant or tolerated. The nuances here is you consider ezetimibe first, and then add PCSK9 if you have them on HIST or max tolerated statin plus ezetimibe. Here are those features that create a very high risk situation. So if you've had acute coronary syndrome, you're greater than or equal to 65, certainly heterozygous FH, and an acute coronary event, prior bypass, diabetes, hypertension. So I won't go through those. You have the slides. And this is within the algorithm itself. It gets messy when you start looking at these for the first time, but clinical ASCVD event, always, we should be discussing lifestyle with all of our patients, regardless of MI or not. But for those that are in that stable or not very high risk, here's where that greater than 75 I was talking about, moderate versus just continue that high intensity statin. But if they're less than 75, high intensity, remember, first minimum goal, and then add on ezetimibe if needed, or switch to moderate intensity if they can't tolerate the HIST. Okay, on the very high risk side, then it's high intensity statin therapy, and then PCSK9, ezetimibe, etc., to get them to less than 70 milligrams per deciliter. So that's that extra step or that extra goal. All right, moving to primary prevention, because then it breaks out into those that have diabetes, those that have, are just 40 to 75 years old, like myself, without diabetes or an LDL cholesterol greater than 190, and then those that have LDL cholesterol greater than 190. Really, the question is statin or no statin. So, we rely on our friend Will Shakespeare to help us out here. But I think the real question is, earlier than 40, you have to say to yourself, what's going to happen to people? Death and taxes, right? They're inevitable. So when are they going to have an ASCVD event? And that 10-year or lifetime risk score is something to think about. So how do we use that? Okay, so now we're going to look at the primary risk side of things. Here we go. Diabetes 1 and 2, 40 to 75 years of age, or LDL cholesterol greater than or equal to 190. I've cheated. I've gone ahead and given you this slide as a way to come back to real quickly and say, well, what did Viet say? Missed here for these folks, HIST, high intensity, missed for these folks, HIST, and then high intensity statin therapy. So at least this is a way to go back real quickly and understand. So the ASCVD calculator, when do you use it? It really is for that middle group. For primary risk stratification, they've not had an MI, stroke, or PAD, they don't have diabetes, and they don't have an LDL cholesterol greater than 190. That's really the majority of everyone else, right? This is what we use, is this ASCVD calculator, and the link is down below for you to copy and paste. All right, but let's take care of the diabetes first. And these are those individuals that have type 1 or 2, age 20 to 39 years of age, or 40 to 75. And again, I've cheated for you and given you kind of the answer ahead of time, but let's break through a case here. So you have a 45-year-old African-American female with type 2 diabetes. She's otherwise healthy, non-smoker, no family history of early CAD. She's not had hypertension, but reasonably on renal protection with lisinopril 5, and her blood pressure is 125/80. Heart rate 68. One argues with HA 2017 blood pressure, she's elevated in her blood pressure. Total cholesterol 200, HDL 35, LDL 125, and 180 triglyceride. No thinking here. She's 45. She fits right into this 40 to 75-year-old. You don't have to do an ASCVD risk score. It's missed. Straight up off the top, of course, you should be educating patients. It should be a shared decision-making process. But for you as a clinician, this takes the guesswork out. They should be on a moderate intensity statin therapy, Torva 10, Rasuva 10, Simba 20 to 40. And then what I like to do here at the very bottom is I like to calculate this for the patient. It's kind of, it's not magical, but it helps to build credibility. I tell them, look, a moderate intensity goes from 30 to 49% reduction. If your baseline is 125 and I calculate this, once we start it, this is what I estimate at the least optimal end, 30% of where your LDL will be. At the most optimal end, it will drop to 64 milligrams per deciliter. And I tell them 3 to 4 weeks, let's get a lab and let's see where it lands. And in general, this is exactly where it lands, is right in between there. And it builds credibility. So then we run into our next patient who's 50 years old. She's also African American female with type 2 diabetes. She is a smoker. no family history of early coronary artery disease, and otherwise healthy. She is on lisinopril 5 milligrams for hypertension. So here she smokes, she has hypertension. And from 50 to 75 years of age with these risk factors, you would say a high intensity statin therapy. I did not change any of her other features here. She's very similar to the 45-year-old. She's 50 though, smokes, and has hypertension. In general, you don't do the ASCVD risk score, but I thought it would be important to look at it so that you can see what happens, right? While we don't use ASCVD scores, this illustrates the high risk and why she needs to be hissed. Remember, greater than 20% is high intensity statin therapy for ASCVD risk. So as I put this in, see if she's diabetic, she smokes, and is on hypertensive treatment, 24.9% 10-year risk. So if you didn't, you're like, oh, yeah, you're just blowing smoke. How is this high intensity? This is why she's greater than 20% 10-year risk when you add in smoking and hypertension. And you could play around with this, add all these back in and take off hypertension, see what happens. Leave hypertension, take off smoking, see what happens. And you'll see it modifies that risk. So here, high intensity statin therapy, again, those two, atorva and rosuvastatin. And then again, now that you, optimally, you would at least get a greater than 50% reduction. And here, if you calculate it for her, is 62.5 down from 125. A great drop in LDL cholesterol, and something that in 3 to 4 weeks you can repeat and say, look, we achieved it. I like to talk about ezetimibe and PCSK9 on this first treatment, just in case, and to get them thinking about it. And a lot of times my patients, after an LDL cholesterol, will text me and say, hey, is it time for the ezetimibe? Should I be on the PCSK9? And it gives a lot more time for us to discuss these things. And really, the patient is the pilot. I'm just the navigator in these health discussions. So primary risk, let's move to the 40 to 75-year-old ASCVD risk. We've taken care of diabetes, missed or hissed, okay? So it's this borderline risk group or intermediate risk group or the high risk group, missed or hissed, okay? So let's look at a case here, 60-year-old Caucasian female with no history of diabetes, hypercholesterolemia, smoking. So we can use this ASCVD. She has hypertension, blood pressure is 135 or 85. She's still stage 1, despite being on medication. And she has a family history of premature coronary disease in her aunt with an MI age 55. So certainly she has some risk here personally. And I put this in here because I think there are times where precision medicine is looking at more than just the ASCVD risk score, okay? She's on lisinopril 20 and her heart rate's 80. Total cholesterol 190, HDL 40, LDL 120, triglycerides 160. Not really anything to shake a stick at, but when you put her into the ASCVD risk score, you'll also say, well, maybe we don't shake a stick at this, right? So as we input, systolic blood pressure 135, diastolic 85, total cholesterol 190, HDL 40, and then LDL cholesterol at 120. She's not diabetic, she doesn't smoke. And what you find is then she is hypertensive. She falls into this intermediate risk, okay? And you'd say, well, gosh, you're 60, intermediate, we could consider statins. And really what would push me over to consider a statin is if you had some other risk factor, like perhaps premature coronary disease in a family member. So, you may consider MIST, and I would say that is appropriate, plus a risk enhancer. And in this case, I think the risk enhancer is that she's 60, but had an aunt who had an MI at age 55. So it's somewhere in the family that this can occur. But moderate intensity, we go on to describe it and discuss it. If she decides no, that's fine, but we go ahead and calculate it for her again as to what may happen if we start moderate intensity statin therapy and what her LDL may land based on that therapy. So now we're looking at the intermediate risk group of 7.5 to less than 20. This is our traditional group that you would say, yeah, we would recommend a statin, not just consider it. Here's a 54-year-old Caucasian male with no history of diabetes or hypercholesterolemia. He smokes, blood pressure 130/90. He has hypertension and a history of premature coronary disease. So, things are kind of, whoa, I'm a little worried because this was your brother who had a stent in a proximal LAD this year, and he came in. So he's seeking information. He wants to know, how risky am I if my brother 1 year older had a stent? This should be part of the discussion. It should fill out the real thought here behind patient care rather than just these risk scores. So we input everything in, and I did it already for us, but look up here at this box where he shakes out at 12.6% as a current smoker on hypertensive treatment. And it really doesn't speak to his family, right? We don't get family history in here. And I would say, yeah, in the least, he's intermediate risk, but I would also argue that because his brother had an event at age 55, my red flags and radar kind of picks up. This is someone that I would consider coronary calcium, although the guidelines would not necessarily promote that at this time. Look for that in the next guidelines. In any case, his LDL is 108. If we start a moderate intensity statin therapy and calculate it, we can really get a good effect, down to even 55 if optimally he responds to that statin therapy. Okay, so here are the risk enhancers for people who are borderline or intermediate, meaning 5 to 7.5 or 7.5 to 20% event rate. And you can kind of see, here his family history. We could also get an Lp(a). It's a little beyond this talk, but think elevated Lpa. We have therapies now in phase 3 clinical trials. We're a site for one of them, the Horizons trial, which is sponsored by Novartis. So anyways, it's something to think about, and more and more you'll see Lp(a). Okay, so moving on to that last group, greater than or equal to 20% risk. And just reading his history here, you'd think, ooh, okay, maybe he is a risky. You get this kind of clinical sense. This 57-year-old Caucasian male, no history of diabetes, hypercholesterolemia, but he smokes, he has hypertension, blood pressure is 130/90. So he's still stage 1, even stage 2 with that diastolic, despite being on hydrochlorothiazide. So we could probably work on that blood pressure. No family history of premature coronary disease, however, and his LDL is 108. So you're like, oh, okay, maybe. Well, we input it, and it's not that different from the prior gentleman at 54, but at 57 and current smoker, you can see he's 23.4% versus the 12% in the prior individual for a 10-year risk score. And so we would start high-intensity statin therapy in him. Okay, again, you can kind of see the difference here. Atorva Rasuva, if we calculate it, certainly optimally treated, he would drop down below 70 at least, but down even to 54. So many times you're not really necessarily having to think about ezetimibe and PCSK9 inhibitors, but it should still be in the back of your mind. Okay, so here, this person with an LDL cholesterol greater than or equal to 190. This is no-brainer as well. In the guidelines, anyone with an LDL cholesterol greater than 190 should be considered for high-intensity statin therapy. So here's a 42-year-old gentleman, no history of diabetes, does not smoke. His blood pressure is 120/80. So you're like, no other risk factors, but his father suffered a heart attack at the age of 45. Remember, he's 42, and that's what's prompted today's consult. So if anything, you should be, let's manage you and reduce that risk because, down the road here, it looks like there's a big bump 3 years later where your father hit something in the road, and we want to reduce that as much as possible for you. So you start high intensity statin therapy. Remember, if his LDL cholesterol is already 205, even a 50% reduction at optimal still leaves him above 100. Now, the guidelines suggest for anyone with an LDL cholesterol of greater than 190 that the goal is less than 100 to shoot for that. So here's someone that you would add ezetimibe or PCSK9 inhibitor. In fact, I calculated for that. So you did add ezetimibe, and we think that that reduces by another about 20%, and it would drop him to 82. So with a high intensity statin therapy and ezetimibe, we get them down to 82 milligrams per deciliter. I wish that were the case on almost all of my FH patients. Yeah, I would say that for many of them, it does happen, but a PCSK9 inhibitor ends up being added as well. Okay, so I've alluded to it. What genetic related disorder do you suspect? You're welcome to put it in the chat if you'd like. As we move forward, we'll discuss these things, but I think this person prompts further evaluation beyond personally treating him. And the reason being is that the disorder I'm talking about is, I'm just forgetting the term right now, but in any case, it's inherited at 50%. So if he has any children, let's say 3 children, well, each child has a 50% probability of also gaining this disorder. And the sooner you can treat, the better. And so I'm gonna cheat and look at the chat real quickly here. Oh, okay, great. Okay, so let's talk about 75-year-old patients. Okay, what do we do with these individuals? Well, here's a retrospective observational trial in France looking at patients who turned 75 and from 2012 to 2014, and then they were followed for 2.5 years almost. So 120,000 patients, 15% of them or 14% discontinued their statins, and they accrued about 4.5% of cardiovascular events. Well, this is what happens, right? So when we look at this, statins continued versus statins discontinued. And remember, they're already 75 years of age. What we find is that there's a 33% increased risk for MACE if you discontinue the statins. So it's still beneficial for these individuals after they hit the age of 75. I mean, it would be easy to say, well, you're 75, you're old. In the US, you're gonna, the common age of death is like 78. But there's still a chance to reduce their event rate if you continue them on statins. Here, we're looking at individuals 65 or older, and this is 29,000 Italian residents who really, they were looking at polypharmacy. This is important, right? I mean, this is why we kind of think of, well, should we start or stop a statin? If there's polypharmacy, they're on 20 meds already, should we discontinue them? So they matched these individuals, 4,000 of them, and what we find is that when they discontinued their statin, it was an increase of 24% events for any cardiovascular outcome, 14% in particular. That's heart failure. And then cardiovascular outcomes, 14% death from any cause. Interestingly enough, not cardiovascular by itself, but 15% increase in any emergency admission for any cause, increased by 12%. So I think that the lesson here is that the reason why you started a statin, there was probably some risk there, and that risk still persists in individuals that are 65, 75 plus, okay? All right, so lipid lowering therapy, just running back through this. Remember, this same chart, dietary fats coming in, that bile acid emulsifies it, becomes micelles, but it has to come through NPC1L1, also called Niemann-Pick, okay? So I think of, and I teach patients, it's kind of like, you're the bouncer at the bar. I don't drink, but I envision this from TV where the big guy that's looking at IDs and checking them, etc. And he just says, look, you're not old enough to come in, okay? I'm ezetimibe, I know what's what. And by the way, we just kicked you out over here and you're trying to come back into the bar. So ezetimibe, 20% of the time drops that cholesterol from coming in. Even though it's become a micelle, it doesn't come through to become a chylomicron, thus reducing cholesterol by another 20%. Here are the bile acids and where they work. So, you're looking at cholestyramine, cholesabolam, where they bind bile acids and don't allow them to latch on and become micelles. So we can have anywhere from 15 to 20% reduction in cholesterol there. Then, this ATP-CL inhibitor, bempedoic acid, recall that once it came through as a chylomicron, it has to come up through and be attached and brought into the liver through ApoE, and it starts this cascade. Well, bempedoic acid is here and statins are here. And if you can, interfere with these, then they do not come forward and become cholesterol, but get kicked out into the gut again. And then lastly, PCSK9 inhibitors here, where they work along the LDL receptor. And that LDL receptor is picking up LDL, bringing it in, degrading it, and then comes back out to grab more. But PCSK9 actually degrades the LDL receptor. So, I think of LDL receptors like this garbage truck, comes out, picks up garbage, but PCSK9 is this overbearing supervisor that says, let me jump on the truck with you. And so they get on the truck, see this wonderful work of taking garbage to the landfill, and then PCSK9 fires LDL receptor and says, you're fired. Well, the inhibitor runs interference with that boss and says, hey, boss, come on over here. Let Fred do his work. So for 2 weeks, that interference works. Someone else has to take over and interfere with PCSK9 inhibitor, or PCSK9. So every 2 weeks, the injection. All right, so coming back to the evidence then, right? Here's ezetimibe. So, we know it lowers cholesterol by 10 to 20%. This is the Improve It trial. When you look at simvastatin and ezetimibe versus simvastatin monotherapy, this is what we saw, is a relative risk reduction of 7%. So it lowered cholesterol by 10 to 20, and that on top of statin allowed for another 7% relative risk reduction. Look, let me make this clear. Don't tell patients that we're preventing anything. They still have events. That's why I call it risk reduction, because simvastatin and ezetimibe, they still have events. They just have 7% less events. We have to understand this when we discuss things with patients. Transparency. And if it's a new drug that costs $300, $400 a month for an additional 7% or 20% reduction, you have to think to yourself, am I preventing or am I reducing risk, and can that patient afford it? So think of that as we implement therapies in patients and make that part of discussion, because financial health is also healthcare. So here's PCSK9 inhibitors, talking of $300, $400 a month. But this is the Fourier and Odyssey trials, okay? What happened here? Well, this is what happened. We had a 15% relative risk reduction for people who are on evolocumab. Remember, they were already on high-intensity statin therapy or max tolerated. Some were statin intolerant, plus minus ezetimibe. But they also, despite that, had an LDL cholesterol that was already low. It was pushed down below 70. So inclusion, for LDL cholesterol was already low to begin with. But you can see people still have events. They just have 15% less events. So the key here is that we know PCSK9 reduces by another 50% cholesterol on top of a high-intensity statin therapy. But it really adds another 15% relative risk reduction. And that's important to know, that there is data that it actually affects the outcome of interest, right? Heart attack, stroke, death. And we're not just lowering cholesterol to lower it, because that leads me to this. Bempedoic acid is an ATP citrate lyase inhibitor. It does lower LDL cholesterol when combined with a statin, only 15%. Without a statin, about 25%. That's interesting. You're like, why? Well, remember, it's in that same cascade. So there may be some features there where statins kind of take care of LDL reduction, and so adding bempedoic with it isn't as effective as bempedoic by itself. And so, this is Nexletol. Just know that there's Nexlizet, which has bempedoic plus ezetimibe, and that can get nearly 49% reduction in cholesterol. We just don't know if it adds to outcomes. So that's Clear Outcomes. That's the name of the trial. Look for it. It will probably be reported out in the end of next year. These are high-risk primary and or secondary risk populations. They are statin intolerant. We need medications for the statin intolerant patient. And so I look forward to the Clear Outcomes data. Stay tuned for that. Okay, so coming to the ESC Congress and updates in lipids. I brought you up to date with 2018 AHA ACC cholesterol management guidelines. But where do we go from here? What are we looking forward to? So how do we overcome clinical lipid-lowering inertia. Well, the Europeans have really addressed this in this algorithm. And so look at this, this is secondary risk population. They already have high risk or extremely high risk. If you want to know what extremely high risk is, right here, post-ACS, plus history of other vascular events. And they go right to it. You start a statin plus ezetimibe. There's no progressive steps here because the inertia, once you start a statin and you say, well, 3 to 4 weeks, and then we'll think about ezetimibe, that 3 to 4 weeks becomes 6 months, becomes 1 to 2 years, becomes, I'm managing other things, I've forgotten about ezetimibe, or I've forgotten about PCSK9 inhibitors. So there's a lot of inertia there with moving cholesterol lowering down. The Europeans have said, look, there's data, there's evidence, let's just start a statin plus ezetimibe in those that we would call stable. In extremely high risk, go ahead and think of the triad: statin, ezetimibe, PCSK9 inhibitor. Don't fool around with this. And if you think about it, it's because of this next section here. We are thinking at 70 milligrams per deciliter. They're thinking at 55 milligrams per deciliter. And honestly, that's where I think as well is if they're greater than 55 milligrams per deciliter, you should be adding therapies, not really 70. I've seen enough people have events, even with LDL cholesterol at baseline of 60, 70 milligrams per deciliter, that lower is better. The data is there for this. We don't necessarily have to think about clinical trials to see that. Observational and Mendelian trials have shown that lower is better and more protective for our patients. So the Europeans have already started there. So add PCSK9 targeted therapy and or bempedoic. I'm not yet ready to go bempedoic until we have clear outcomes trials, and that's reported out. Okay, coming to familial hypercholesterolemia. FH, family history, high cholesterol. There you go, familial hypercholesterolemia. If they have an early event in their family and or their personal high cholesterol, excuse me, I'm running over myself, their personal cholesterol is elevated, greater than 190 for adults, greater than 160 in children. And actually, I'm going to say from 0 to 39 years of age. So for those of you younger than 40, I've just called you a child, and I apologize. That's not demeaning. It's just to say that you have a long life ahead of you, and I want you to live it. So, but think about familial hypercholesterolemia here. Okay, the obvious signs would be this on a physical exam, where you're seeing tendon xanthomas, right? The Achilles tendon, really, if you just gripped yours right now, you might be able to pinch ½ an inch, probably less. If it's thick, 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 and I kind of have cankles, so my ankles are a little bit thick, but even then, the Achilles tendon is not that thick. When you have someone that has tendon xanthomas, that's really thick. When you start to see xanthelasmas like this lipid deposition, because it's so high, LDL 190, 200, 400 for homozygous FH, and actually greater than 600 to 1,000 in homozygous FH, then it starts to deposit places. This is probably the most common area to see it is arcus. We commonly call this arcus senilis because it's in those older, but if they're less than 45 years of age and they have arcus, really suspect familial hypercholesterolemia. Okay, so here, just a plug for the CardioSmart. I'm one of the editors for the CardioSmart Heart Explorer app. This is great to have in your office. You can download it from the cardiosmart.org website, and here is the link itself. Fantastic to have in your clinics. So why am I so passionate about this and wanting people to be treated and identified? So in males that are 50 years of age, the risk of an event of a heart attack is about 6% at age 50. Look what happens in an untreated FH male. 6% versus half. So if you have FH, you're untreated, you're under the age of 50, flip a coin and you'll probably have a heart attack. For females at age 60, 5% event rate in a normal population. It's 30% for those that are untreated under the age of 60 and female. 1 in 3. This is intolerable. It's intolerable that this happens, and we need to identify these individuals and treat them. And that's why cascade screening is important, because the earlier you can treat them, the less burden of cholesterol they have over their lifetime. So where do we find them? This is a little bit too late because it's a cohort of individuals that presented with STEMI, about 2,000, and their average age or median age was 45 years old. 20% of them were female, and half of them had STEMI. So 180 met criteria for probable or definite FH. That's of the 2,000, 9% of them. And then 42% were not on a statin at the time of event. Remember that criteria is an LDL cholesterol greater than 190. Half of them were not treated at the time of their STEMI. Half of them were not treated, or 42%, okay, close to half. So clinically diagnosed FH was present in 1 in 10. Here we go. So these are young patients, 45 median age, that were presenting with an MI. 1 in 10 will be definite FH. If they were the same age with an event but had a family history, 2 in 10 or 1 in 5. If they were a young adult with an MI, but their low density lipoprotein was greater than or equal to 160, remember I said from birth to 39 years of age, LDL of greater than or equal to 160, it's 4 in 10. For those that have an MI before the age of 45, had a family history of someone else having an event prematurely, and their own LDL cholesterol is greater than or equal to 160, 6 in 10. It's too late, but if you see these patients, begin cascade screening, okay? Because 43% of them were not on statins to begin with before their event, and really only 49% were discharged on a high intensity. This is someone that's having a heart attack at the age of 45, and they're not being placed on a high intensity statin therapy. So there's inertia. There's inertia with knowledge of how to treat these individuals. So understand this. Okay, so where is my passion with regards to early management of this and early identification? These are 214 children that have FH. And they were randomized in a double-blind placebo-controlled trial to being on pravastatin versus not. Remember, 1997, we didn't have a lot of data on young kids and starting cholesterol medications. Now I would put someone that's 10 years of age on statin, rosuvastatin 5, 10 milligrams. I wouldn't even blink because we have safety data. But 1997, they randomized these to pravastatin and followed them for 20 years. And you can kind of see here, their unaffected siblings, baseline follow-up versus the baseline of these hypercholesterolemia patients. I mean, look, 160 on up to 400, and then where you were able to push their follow-up cholesterols. It's a pretty wide confidence interval, but we were able to get them to 150 on pravastatin. It's not a very high intensity medication, but baseline for their siblings are already low to begin with, okay? So here, this is what's so cool about this. If you have children with FH and you start therapy, statin therapy early, this is from cardiovascular events, freedom from, 100% survival from events. Look what happens. You almost normalize or even improve it over the regular population. People with definite FH, you start statin early versus what happens to their parents. These are their parents and their event. Look at what age that is, 39 and nearly 55% with an event versus their children. That is a huge relative risk reduction when you can start statin therapy. Now, something you can't walk back from is death. You just can't walk back from death. You die, you die. And I'm not saying that cavalierly, but here, 39 years of age, none of those children that were randomized to pravastatin died. If I can't make that any more clear, we have the ability to identify these children if we identify their parents and begin cascade screening, and we have the ability to start therapy early and keep these folks alive. So please, 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 please think of FH when you are seeing patients, and refer early to genetic counseling and to my clinic if you want to, but I'm in Utah. Consider referring to a lipid specialist. So, if you have a suspicion for the presence of FH and you want to do genetic testing, here are the definitions. You can look at the slide later. Premature coronary disease, one would argue are moderate intensity statin therapy patient who's 55 and a brother or 54 with a brother at 55 could have been tested. If they have a poor response or less than expected with LDL cholesterol, so it's blunted for some reason, you started a high intensity, but they get like 20% reduction, something else is going on there, and that should prompt the lipid specialist referral. Presence of comorbid severe lipid derangement, so triglycerides greater than 1,000. I've got a patient now with greater than 7,000, actually several greater than 5,000, and HDL is less than 30. And then persistent elevated LDL despite statins and initiation of non-statin therapy. Something else is going on, and that's driving that we should assess further. So here's the summary. These are the full 4 cohorts. Secondary risk is very easy. You start high intensity statin therapy. The question is ezetimibe and PCSK9. On the other side for the primary risk, then you're just, you're trying to decide moderate intensity versus high intensity, or whether, they don't have to be on a statin at all versus those that should be on a statin. I didn't address coronary calcium. That's for another talk. If you ever want to bring me back, we can talk about coronary calcium and how it works, how I implement it, and what my thoughts are. But these are the full 4 cohorts. In summary, so, initial intensity of therapy and threshold for adding non-statins are based on the initial assessment. You should continue to assess them. If at the age of 60, they were borderline risk, probably the next year at 61, they become intermediate because age is factored into the ASCVD risk score. So the assessment should be ongoing because your patient's still alive. That means they still have the propensity for coronary disease. So moderate intensity statin therapy, here are the examples: diabetes, ASCVD risk score 10-year 5 to less than 20%. High intensity, so a greater than 50% decrease in LDL. These are the examples: diabetes with risk enhancers, ASCVD 10-year greater than or equal to 20, or they have MI, stroke, PAD. Target those LDL cholesterols to less than 100 when the baseline is greater than or equal to 190. Of course, if this individual, this FH individual, has an event, they are very high risk, and you would want to shoot for less than 70. I like to go to less or 55 or less. And then target LDL cholesterol to less than 70. Again, consider lower when someone's very high risk. Think of the Europeans and what they're doing, looking for 55 milligrams per deciliter and lower. Have a lower threshold for identifying FH. We can truly impact these individuals. Now, what I didn't mention here that was in our Twitter poll, if you happen to discover that, is that while we recognize the impact of FH, 90% is felt to be undiagnosed. So we really only uncover about 10% of FH. And those that are diagnosed currently with FH, that's only 10%. We're barely hitting the tip of the iceberg. And there's a whole bunch of people out there and their children and their siblings and their cousins that are at risk. And so that's why we should be identifying FH. So now I'm gonna ask our moderators whether they want me to go through these questions, or are these questions that you would prefer audience members do on their own?
So in light of timing, I think we're going to move these questions to kind of self-assessment for participants. I do have a question for you from the chat, if I can take that. One of the participants asks, I see many bariatric patients that have high numbers and want to wait to start their statin until after weight loss surgery. How soon after weight loss should they get their lipids checked?
Oh, I think that's, so it's interesting. Bariatric patients have almost immediate changes in their glucose. And I would say 3 to 4 weeks is fine. It would almost be like an intervention adding on a lipid. I would check within, if you want to be conservative, go to 3 to 6 weeks and see what their lipids look like at that point. Obviously, there's going to be a lot of dietary changes they go through with bariatric surgery, but an LDL cholesterol done, latest 6 weeks will give you a sense of whether or not to consider initiating statin there, or then going on 6 months to a year later for annual follow-up, kind of return to regular assessments again.
Great, thank you.
Yeah.
All right. I believe those are all the immediate questions that we have right now from the chat. I see Kathy put her video on. Kathy, did you have a question?
No, I just think I'm up next. So.
Okay. Oh, sorry.
No problem.
Okay, fantastic. Yeah, thank you so much for joining us today. This was excellent and a really great update and overview for lipid management, and we really appreciate your time and your expertise.
Thank you. All right.
Thank you, Michelle. Thank you, Viet. What an excellent presentation, walking us through the conundrum of lipid management, walking us through the primary and secondary prevention models and the data along with it. We see the passion. We are excited. If no one is, I am excited about the lipid management. Also, as we had mentioned, please consider consulting the lipid panelist when you run into situations, and use the tools that we had mentioned. All right, we are on to the next topic. And continue to post your questions in the chat window. And as Liana mentioned, thank you. There are no pre-tests. I think you would get notifications for the post-test. Now, on to the next topic is on pulmonary hypertension, updates on it. And think of it, the heart, in the center of the heart, to the two sides is the matrix of the lung. And the pulmonary circulation plays a vital role in the cardiopulmonary function, exchanging gas and oxygen transport. Its central position, however, renders the pulmonary circulation to a high rate of injury or acquired disorders affecting the heart and lungs. And pulmonary hypertension is continuing to be challenging, and it's complex. And I'm going to hand out, without going into much details, I don't want to steal it from Kathy. I'm going to hand it over to Kathy to speak more about it. But a little bit about, let me introduce Kathy to the members here. Kathy is a nurse practitioner from UCLA, board certified. She's an acute care nurse practitioner with a background in cardiology and pulmonary and critical care over the past 35 years at UCLA Medical Center. Kathy worked with UCLA Pulmonary Vascular Disease Program from 2011 until 2021. Kathy has practiced in both outpatient and inpatient areas, treating patients with all types of pulmonary hypertension. She has a particular interest in utilizing and promoting adherence to advanced therapy in pulmonary hypertension and health-related quality of life in PH patients. Although Kathy is recently retired, you know what retired means. That's just for the title and it at the job, but it never in life. So you can see Kathy smile away. She plans to remain active, and she is, as a great witness today, she is, remains active in the PH medical and nursing communities. Hand it to you, Kathy.
Hi, thank you. Thanks, everybody. It's just a pleasure to be here today. I'm going to share my screen right now. And please let me know if there's any issues with the screen. You should all be able to see it. These are my disclosures. And this is my stomping grounds. And as Jonathan mentioned, I did retire from UCLA. My husband and I had an opportunity to purchase a lovely farm property in New England. But I still consider LA and UCLA my home, and the pulmonary vascular disease service at UCLA is now quite a large service, and we're one of the largest programs in Southern California, if not California. So today I'm going to talk to you all about pulmonary hypertension. And that is a condition, as Jonathan eloquently outlined, which can be very complex and actually very sort of nerve-wracking for providers. So my goal today is just to give you a broad overview of pulmonary hypertension, how we define it, how we diagnose it, how we treat it. So I'll start out here with this definition, a hemodynamic definition of pulmonary hypertension. And basically, pH is a hemodynamic finding. As we'll see shortly, diagnosis is dependent on an accurate right heart catheterization. pH can be, easily defined as a pulmonary artery pressure, a mean pulmonary artery pressure above normal. Let me just see one thing here. So what are the causes of pH? As we'll see in a minute, we don't really know the exact mechanism behind pulmonary hypertension, but we do know that we can look at different types of pulmonary hypertension. For example, pulmonary venous congestion, which is actually extremely common, and all of you may have seen in your practices. This really is a high pressure system from a stiff or somewhat decompensated left ventricle where blood backs up and pressure backs up as well into the lung. We all are familiar with nursing 101 with hypoxic pulmonary vasoconstriction, but this is a real phenomenon, actually can cause elevated pulmonary pressures in the vascular bed of the lung. And then obstruction from clots and tumors can also lead to pulmonary hypertension. There is, however, one type of pulmonary hypertension that I think we can all recognize as deadly, and that's pulmonary arterial hypertension. And we never want to miss that. And those are diseased pulmonary arterioles in the pulmonary vascular bed that, if left untreated, leads to right heart failure, and in many cases, ultimately death. Now, pulmonary hypertension, I always like to use as a blanket or an umbrella term because not all pH is PAH. So,
I'm sorry to interrupt you, Kathy. We're having a little bit of issue with your slide deck.
I am.
Okay. All right, I think we are good now. Thank you so much.
Oh, okay, great, thank you.
If you're able to presenter mode, that may be helpful. Let's see.
Let me just see. There we go. Now I can at least advance. Keep me posted on that if there's any more problems. So I mentioned that the right heart cath is instrumental in diagnosing pulmonary hypertension. When we look at pH in general, the definition is a mean pulmonary artery pressure greater or equal to 25 millimeters of mercury. In order to diagnose pulmonary arterial hypertension, or PAH, you still need to have a mean pulmonary artery pressure of greater than 25 millimeters mercury, but you must also demonstrate that left heart function is normal. So we want to see a left ventricular end diastolic pressure on a left heart cath or a wedge pressure of less than or equal to 15 on a right heart catheterization. And I will say I like to bring up both of those measurements to assess left heart or left-sided pressures, because in patients with pulmonary hypertension, the PA can be just massive, and it can often be difficult to get a wedge pressure that's accurate. And there is a study out of 2009 where, looking at over 2,000 patients, about 53% of those patients had a wedge on right heart cath less than 15, but they had a subsequent or simultaneous LV EDP greater than 15. So you really need to have the right heart cath if you suspect PAH done by a very good cardiologist or pulmonologist who specializes in really understanding the pulmonary vasculature. The ACC AHA may also include a PVR of greater than 3 Woods units in that definition. One thing that's happening now in the World Health Organization is that they are re-looking at this definition of pH and considering changing, which has not occurred yet, the mean pulmonary artery pressure to equal to or greater than 20 millimeters mercury. So we'll keep you posted on that. So when we look at pulmonary hypertension, it's super helpful to understand the WHO group classifications of pH. And this really helps us break down pulmonary hypertension into 5 categories or groups. The first WHO group to help us understand pH is WHO group 1, which speaks to that PAH, pulmonary arterial hypertension, that we never want to miss. About 40% or 40 to 50% of those patients have idiopathic PH, which PAH with no known cause. Some of these patients have heritable PH. It's a smaller number, which I'll show you in a moment, where there's some gene mutation, and we know there's a particular one called the BMPR2. Drug and toxin-induced PAH, specifically methamphetamine, which is a real problem in many areas of the country, and especially in California, can also cause PAH. Other conditions that fall under WHO group 1 are associated conditions. And what really stands out, and I'll show you in the next slide, are those patients with autoimmune diseases, specifically the connective tissue diseases such as scleroderma and rheumatoid arthritis. Persistent pulmonary hypertension of the newborn is listed here, which I won't be able to be going into. And then there's WHO group 1 prime, and this is a condition called pulmonary veno-occlusive disease, where not only is the pulmonary artery pressure elevated due to pathology in the arteries, but there's also pathology in the veins. And so this is rare, and it's usually diagnosed on autopsy or a diagnosis of exclusion. And I won't be going into that on this lecture. It could be its own lecture. But WHO group, so WHO group 2. WHO group 2 is that pulmonary venous hypertension related to left heart disease. And I think of that stiff left ventricle causing a backup of pressure into the lungs. We see this in certain patients with systolic dysfunction and with diastolic dysfunction, and also with certain valvular heart diseases. The treatment for WHO group 2 is not very specific pH-directed therapies, which we'll talk about later. It's actually treating the underlying cause, such as hypertension or cardiomyopathy. In WHO group 3, these are characterized as the lung or hypoxia-related PH patients. They tend to have lower PA pressures than some of the other types of pulmonary hypertension. But we see this with COPD, for example, interstitial lung disease. Sleep disordered breathing is a big one. I'll be interested to hear about heart failure management, because if we really target sleep disordered breathing, we can actually improve pulmonary hypertension in those patients. WHO group 4, I have a slide for you coming up. This is a very specialized group. It's from chronic thromboembolic phenomena that actually mimic pulmonary hypertension. And we see these in patients who have persistent shortness of breath 3 to 6 months after treatment for a PE with adequate anticoagulation. So we never want to miss WHO group 4 because there is a curative surgery, which I will show you coming up here. And then finally, WHO group 5 PH is really sort of a potpourri of diagnoses and conditions with unclear and often multifactorial mechanisms which lead to PH, such as sickle cell anemia, various other anemias. Again, I just want to highlight that WHO group 1 PH is pulmonary arterial hypertension, and that carries the worst prognosis. Having said that, is it the most common type of pulmonary hypertension? Well, this study, even though it's a bit older, speaks to a single echo lab in an Australian community of over 150,000 people. They looked at numerous echoes of about 4,500 patients. And out of those, about 483 had pulmonary hypertension noted on echo. And what we see on echo when we suspect pulmonary hypertension is a PA systolic pressure, not to be confused with the mean, of greater than 40 millimeters mercury. So when they brought these patients to heart cath, you can see here in this diagram that the largest number of patients who had PH actually had left heart disease. When we look at PAH out of that particular cohort, it was only about 2.3% of all patients. And you can see here congenital heart disease, lung disease, also a smaller number, but well over three-quarters had left heart disease. So when we look at pulmonary hypertension in our daily clinical practices, we never want to miss PAH, but just keep in mind the patients that many of you see may have pulmonary hypertension secondary to left heart disease. So now I want to shift gears to pulmonary arterial hypertension, because I do think in cardiology, we're all going to meet these patients at some point. PAH is still considered somewhat a rare disease, although we're much better at diagnosing and treating it now. Prevalence is anywhere from 15 to 50 per million, approximately 1,000 plus new cases every year diagnosed in the US. And that working in a big center, I was like, oh, that seems low. But for decades, the mean age of diagnosis was always thought to be in the second and third decade of life. And what we know now, after having more data and large registries throughout the world, is that the mean age of diagnosis is somewhere in the fourth and fifth decades of life. And we're seeing elderly people, sixth, seventh, and even eighth decades of life being diagnosed with pulmonary hypertension. It remains a predominantly female disease, and you can see here predominantly Caucasian, but it does not discriminate. So going back to WHO Group 1, I just wanted to point out when we look at some of the populations within that category, again, idiopathic, I like to just round it up to about 50% of patients will have idiopathic PH where we can't find a cause or we can't initially find a cause. I mentioned familial, the stats today are still around 4% of patients will have a familial or heritable PAH. Anorexin-induced and drugs and toxins comes in at about 3 to 10% of patients. And I will say that fen-phen was a big offensive drug in these patients, and I still query patients for that who may have taken diet drugs, because we tend to see obesity in PH as well. If a patient can't remember, just ask it was a bright orange little pill. Sometimes that will jog their memory. Connective tissue disease, I have bolded here. About upwards of 30% of patients will have some form of connective tissue disease. Scleroderma and PH is probably one of our most rapidly progressive types of PAH. So those patients are automatically moved into a high-risk category. In the northern US, idiopathic and connective tissue accounts for predominantly most of the cases we see. Congenital heart disease and people who have uncorrected congenital heart disease or right to left shunts accounts for about 11% of PH. However, it's very prevalent in China because many patients are not corrected. Portal pulmonary hypertension, about 7 to 10%, and then HIV associated, about 6% of patients may have that as an associated condition. This is an older survival curve in PAH, but I wanted to show it to you because I have a chart that we can contrast with this as well. And, this was back from 2004, but congenital heart disease carried a fairly good prognosis. And we feel because patients were compensated from a young age. Idiopathic PAH came in sort of second in terms of survival. And you can see connective tissue disease, PAH, with very poor survival numbers. HIV has actually improved in the advent of heart therapy. So those patients actually do much better if their HIV is controlled. So I wanted to show you this sort of very busy slide here, because what we have had happen over the last 2 decades is multiple registries. And so we can really get an idea of the age at diagnosis, the percentage of men versus women, et cetera, and estimated survivals at 1 and 3 years. And when we look here, the REVEAL registry is the US registry, and the mean age of diagnosis, again, was in that 5th decade of life. And the majority of patients were women with either functional class 3 or 4 presentation. But at 1 year, survival is at 91%. And if you look back on this graph, we're doing better than we were even, a decade and a half ago. And then there's similar, the Compara and the French registries are also similar to our REVEAL registry. So although they're not randomized trials, we get a lot of very good epidemiologic information from these registries. So pulmonary arterial hypertension, focusing on that, why does it develop? Well, we know it's a chronic and severe cardiopulmonary disorder. It's actually caused by cellular proliferation and fibrosis of the small pulmonary arteries. Over time, if that's not treated, it leads to increases in pulmonary vascular resistance, which ultimately lead to right heart dysfunction and failure. So although, this pathogenesis, which we'll look at, begins in the lungs, the demise of the patient, again, is that right heart failure. So why does PAH develop? We do not know. We don't have an exact cause of what triggers pulmonary hypertension. We do know it's complex and multifactorial. The main gist here is endothelial dysfunction, which occurs early in the disease pathogenesis and leads to endothelial and smooth muscle proliferation in the small arterioles of the lungs, remodeling of these vessel walls, and impaired production of endogenous vasodilators, which we'll talk about, including but not limited to nitric oxide and prostacyclin, and then overexpression of certain vasoconstrictors, and one of which is called endothelin. I love a picture. A picture's worth 1,000 words. So here are some pictures at the cellular level or microscopic level, and then just some schematics here. To your far left is a normal artery with pulmonary artery with a normal vessel wall. But we know as pulmonary hypertension progresses, what we see from this chronic state of vasoconstriction is that smooth muscle hypertrophy develops within the vessel wall, and there's early intimal proliferation. When it's left untreated, you can see what these advanced vascular lesions are characterized by. Again, this gross smooth muscle hypertrophy, proliferation of the intima and the adventitial layers. Over time, these patients will develop in situ thrombosis, small little clots, and these lesions, which are called plexiform lesions. So you can see in the late stages that patients have near obstruction of the pulmonary vasculature. Over time, this increases the pulmonary vascular resistance, which is the afterload of the right ventricle. So again, not to belabor the point, but the problem is in the lungs, but the end result is right ventricular hypertrophy and failure. And this is a schematic of an actual heart of a patient with pulmonary hypertension. And you can just see this massive RV. And if you look over to the right here, the left ventricle itself is, it's just being squished. So it's very small. In pulmonary hypertension, we currently have approved PAH therapies to target 3 main signaling pathways that are central in the control of pulmonary vasomotor tone and vascular cell proliferation. We're going to go over these more in depth when we talk about therapeutic medications, but these pathways include the endothelin pathway, which I mentioned earlier. Endothelin is probably one of the most potent vasoconstrictors in our bodies, and there is an upregulation for unknown reasons in PAH. Nitric oxide, as we're all well familiar with, is a precursor to stimulating cyclic GMP, which leads to vascular vasodilatation and relaxation. Nitric oxide in pH is downregulated, so this pathway is not effective. And then prostacyclin. We all have endogenous prostacyclin, which is probably one of the most important mediators for vasodilatation and anti-proliferation within the blood vessels. In PAH, for unknown reasons, prostacyclins are downregulated. So what does this all mean? So we've looked at these pathways, we've looked at what happens within the vessel wall. Well, this is a nice schematic of progression of PAH, and it's actually a synthesis of both human and animal models. You can categorize pulmonary hypertension into 3 rough stages: the pre-symptomatic, compensated stage, symptomatic and decompensated, and declining and decompensated. And really, when we look at the pre-symptomatic compensated, what we're seeing here is that we're starting to have increases in pulmonary arterial pressure, increased PA pressure, with concomitant increase in PVR. But in this stage, cardiac output is preserved. So patients may feel short of breath or just not really know their exercise tolerance hasn't been that limited. What happens though over time when patients are not treated is that cardiac output in the symptomatic and decompensating phase will gradually start to fall. But unfortunately, pulmonary artery pressure and PVR continue to rise. And you can see in the final stage in decompensated pulmonary hypertension, you've got an elevation, a marked elevation in PVR. Cardiac output has continued to fall, but now even PA pressures are continuing to fall because the RV can't generate a pressure because it's gotten so weak. In this stage, or between the symptomatic and the declining, the right ventricle will try to adapt. Remember our compensatory mechanisms. It will increase its wall thickness, it will increase its size, but those mechanisms are easily overwhelmed. So when we look at RV failure, and we can actually just really sort of pinpoint the chronic changes due to pH. So again, when we've got this pulmonary vascular bed with increasing PVR, this leads to an increased load on the right ventricle. And I just think of afterload for the right ventricle. The RV again will adapt by increasing muscle contractility and what we call, and the wall thickness, which we call coupling. So to maintain that cardiac output, the RV dilates, the heart rate increases, and then we'll see an increase in wall stress and oxygen consumption as well. As the RV dilates out, the septum will actually sort of flatten or bow into the left ventricle. And you may see that on echo as a D-shaped ventricle. In the final stages, uncoupling occurs, and there's this high metabolic demand. And actually, we even see patients come in with troponin bumps from RV ischemia and reduced cardiac output. Unfortunately, even though we're better at diagnosing PH, oftentimes patients present to us in these later stages. Just to take a break for 1 second from PAH, I wanted to just give you some information on WHO Group 4 PH, which is CTEPH, or chronic thromboembolic pulmonary hypertension. And again, this is a condition where patients may or may not have even known they had a pulmonary embolism. But what happens in the months following PE, despite adequate anticoagulation or without, they develop small emboli in these small arterioles of the pulmonary vasculature. Interestingly, one of the tests that we use now quite for every patient is called the VQ scan, because what we're looking for here are signs of chronic disease versus a CT, which we may have gotten initially, which shows us more acute disease. What we look at here, and you can see on the perfusion scan, is called the wedge defect. And basically it's just like a triangular wedge is just chomped out of that lung where there's no perfusion. So once we have a high suspicion for CTEPH, we will send patients for a pulmonary angiogram. And you can see that on the bottom two schematics or pictures here. And really you can see where there's just cutoff of these pulmonary branches and other findings such as pouches and bands. In some cases, we can refer patients to surgery for a pulmonary thromboendarterectomy. And that's where a surgeon who has to be skilled in this procedure, because it's very high risk, the patients are put under circulatory arrest for this. He can remove the white clot. And you can see that in the lower right-hand corner, and it's very dramatic. In many cases, these pulmonary endarterectomies are curative. So we never want to miss these patients on our workup. So is there a reason to suspect PAH in your patients? And there definitely is. And many of the patients who finally make it to a PH center, they tell us, I have been misdiagnosed for years. I have been short of breath. I was told to lose weight. I was prescribed antibiotics. I was given inhalers. Nothing worked. So if you have a workup for a patient and you're coming up, negative, look at their symptoms. The most common initial or presenting symptom is dyspnea, and it's dyspnea on exertion. Most of these patients are not short of breath at rest. They are all fatigued. Those tend to be the main things. If a patient presents with syncope of unknown etiology, suspect PAH, because remember we talked about in that late decompensated stage where cardiac output falls. I've had patients who were at the airport and they tried to run to get to a plane and they passed out in the airport. So syncope is a late sign and one that we don't want to miss. Chest pain, palpitations can happen with that increased RV demand. And lower extremity edema is, a key feature of right heart failure. On history, again, this is all outlined for you there, but physical exam as well can give you some key clues to if a patient has PH. And I would really listen closely at the apex for a loud P2, the second heart sound. The pulmonic component almost sounds like a slap. And once you get in tune to it, you can't miss it. Some patients will have an RV lift or an S4 of the RV. On exam too, when patients are in RV failure, I mentioned lower extremity edema, looking at their jugular venous distension is extremely helpful. So what is the workup for pulmonary hypertension? And this is a busy slide, but if you look at the pivotal test in blue, it's very helpful. And a really thorough history is very important to look for those associated conditions with PAH. A chest x-ray and an EKG are helpful, but your entry test is going to be the echo, and I'll show you that in just a minute. In all patients, again, we get a VQ scan if we suspect PH because we don't want to miss CTEPH. We'll get PFTs and overnight oximetry to exclude underlying lung disease, HIV, ANA, LFTs to look for HIV, autoimmune conditions, liver disease. All of our patients will get a 6-minute walk test. And eventually, based on our findings, patients will go to right heart cath. Here's a chest x-ray. This is an actual chest x-ray of one of our patients with PH. And I think what's most notable to all of us is the massive cardiomegaly. I mean, and you know, what we see is that their right heart gets so big, it actually compresses their lung. It's a little bit more difficult to see on this particular slide, but we look for what we call distal pruning, because you get obliteration of the distal vessels, and you may note that on certain scans. On CT scan, you'll see cardiomegaly again. You'll be able to see the RV enlargement, right atrial enlargement, but you don't see a lot of fluid in the lungs. These patients don't have rails. We see pulmonary nodules, ground glass opacities. The echo is your ticket. And on echo, the things to look for are to look at the right ventricle. Most of these patients with who've had longstanding PH will have RV enlargement and RV hypertrophy. They'll have right atrial enlargement. I mentioned earlier flattening of the intraventricular septum, and it can also be called a D-shaped septum. And if you look here, I'm trying to outline the left ventricle here for you. It's a very small, smushed chamber now. So this is someone with long-standing PH. There's other features we look at that I would go into in a different lecture that speak specifically to increased pulmonary vascular resistance. One of them is called the TAPSE, which I'd be happy to share with anybody after the lecture. Again, right heart catheterization is the gold standard. You cannot diagnose any of the 5 WHO groups without a right heart cath. And sometimes people come to us on treatment not having had that. We, all centers do something called vasoreactivity testing, where we give patients either nitric oxide or adenosine to see if they have a marked response in terms of lowering of the PA pressure. It's very specific parameters while maintaining their cardiac output. About 2 to 4% of patients will be vasoreactive and may be candidates for a calcium channel blocker, but most are not. Again, we might need to have a left heart cath to get an LVEDP if we're having trouble with the wedge or we don't believe the wedge. We also use the right heart cath clinically to evaluate response to treatment. We'll try to get right heart caths, annually or as needed. We use it often in-house to manage and evaluate volume status, or people who just are failing therapeutically. They're hypotensive and not responding to treatment, or they're requiring escalating doses of inotropes or pressors, and in that setting often have worsening renal function. So what are our treatment goals for PAH? Well, of course, it's to improve symptoms and quality of life, but it's also to improve survival. And unfortunately, despite the therapeutic advances we've had over the last 2 decades, survival is still dismal. We use now a goal-oriented therapy involving what we call risk assessment, and I'll share that with you on the next slide. And we're always looking at, in our risk assessment, at objective assessments to measure, because we have to follow these patients closely, because their risk of decompensating even on therapy is a very real risk. So we're looking for improvements in exercise capacity and functional class, hemodynamics, their echo, BMP, and 6-minute walk test. So this is a widely used risk assessment tool. We actually have calculators that we can use in clinic to estimate a patient's risk of dying at 1 year after diagnosis. But in particular, I use this at every patient encounter, because if somebody is moving from a lower risk to a higher risk category, we can't wait. We have to get on it. We have to get them treatment because it's a progressive condition. So the determinants of risk have specific categories, which include clinical evidence of RV failure, how fast symptoms progress, their functional class, their 6-minute walk distance. So for example, if a patient presents and they have a 6-minute walk distance under 300 meters, they're in a higher risk category for failure. We look at CPET or cardiopulmonary exercise testing. We look at the echo. And what I want to point out here on the echo is that we don't look at the PA pressure. We're looking at RV enlargement and dysfunction, the presence or absence of a pericardial effusion. If it's present, that's a late sign, so we've got to get moving, and right atrial enlargement. Hemodynamics, similarly, we're not looking at the PA pressure to determine risk. We are, though, looking at the cardiac index. How well is that cardiovascular system able to function with this high PVR? So if a cardiac patient has a cardiac index less than 2.0, we're very concerned, and we're going to move forward and get them on more therapy. And also a right atrial pressure greater than 20, it's obvious that that's a more higher risk patient. And we'll also see in the high risk patients that they'll have significantly elevated BNPs. So if someone has a BNP less than 100, you still have that great negative predictive value. So I hope I'm doing okay on time here. Just let me know. So treatment guidelines. And I apologize, I don't have this reference for you, but this is from the ERS ECS practice guidelines from 2015 for pulmonary hypertension. So once PAH is confirmed at an expert center and a patient has undergone vasoreactivity, if they're not vasoreactive, then we're going to go down a treatment algorithm. All patients, however, though, will require, to a certain extent, what we call general measures and supportive therapy. And back in the 1990s, when I was a CCU nurse and earlier, this was all we had. So again, these patients tend not to be hypoxic, but they can be. So, you know, we want to give an aim for O2 sat over 90. We use it to prevent hypoxic vasoconstriction. So most patients will need some sort of sleep evaluation. And just remember, if a patient has a shunt in CHD, this, you may not correct their hypoxia. Digoxin is, there's no long-term data on the use of dig. However, there is felt to be some benefit to contractility of the RV. So it's a variable inotropic effect and use. We need to balance those unproven benefits with known risks. So it has to be the right patient. Most all patients will need some form of diuretic for volume overload for a failing RV. And I like to put in here, hypotension is not a contraindication, because once we unload the right side of the heart, we get this volume off, we often see patients' blood pressure and cardiac improve because we have forward flow to the left side. Anticoagulation in the early years of pulmonary hypertension, all patients were anticoagulated for that thrombosis in situ. Now we recommend it only in idiopathic and in certain patients because, again, we don't have strong data to support its use. And there are, complications with anticoagulation. So we tend to run a lower INR in patients who are on Coumadin, for example, in PAH. Moving on, this slide is more of an information slide for you to have if you're interested. Over the last decade, we have had major advances from having, one medication to treat pulmonary hypertension, which was Flolan in the old days, to now 14 different medications. In addition, which I'll outline for you in a moment, we've had clinical trials since about 2014 that demonstrate that using one or more of these medications at a time, what we call combination therapy, improves outcomes in these patients. So what are the medications? And again, remember back to our those pathways that we're targeting. Again, all of us have endogenous prostacyclin. However, in this condition, it's downregulated. So we use prostacyclin analogs for patients, including epoprostenol, which is Flolan, treprostinil, which is Remodulin. Treprostinil can be given sub-Q or intravenous. we tend to use these in class 3 and class 4 patients. Iloprost is a very difficult drug to use, so it's not used that much, but it's an inhaled form of prostacyclin. And again, using prostacyclin increases, it's going to stimulate that cyclic GMP, which will lead to vasodilatation of the pulmonary vascular bed, and there's anti-proliferative effects and antithrombotic effects of the prostacyclins as well. Selexipag is a prostacyclin IP receptor. So that just works earlier in the pathway, and it's an oral medication, and it's used mostly in functional class 2 or 3 patients. It's not used in patients with significant right heart failure at the get-go. Endothelin receptor agonist. Remember, we mentioned endothelin is a very potent vasoconstrictor in the pulmonary vascular bed, and we have 3 endothelin receptor agonists, which blocks that and induces vasodilatation. Ambrisentan and macitentan are once-a-day drugs and the most widely used currently. In addition, finally, we have the nitric oxide pathway. And I think a lot of us in cardiology are familiar with the PDE5 inhibitors. We use sildenafil or Viagra. I try not to call it Viagra in pulmonary arterial hypertension because I can't get it covered by the insurance. So it stays sildenafil and tadalafil. Now, nitric oxide is a precursor to cyclic GMP, so it's a potent vasodilator in the pulmonary vascular bed, lots of nitric oxide. But the PDE5, and especially PDE5, is prevalent in the lungs as well, and that breaks down cyclic GMP. So we want to block that so we can optimize that pathway. And then finally, soluble guanylate cyclase is also in the nitric oxide pathway. SGC actually directly stimulates cyclic GMP to induce vasodilatation. So riociguat was approved earlier in the last decade. And this medication is very similar to the PDE5 inhibitors in terms of how to give the medication. I've got the dosing here. One of the things I wanted for all of the pulmonary vasodilators was to emphasize that these medications are approved for WHO group 1 PAH. They're not approved for the other WHO groups. In addition, because they vasodilate in the lungs, they also can have some systemic effects. So I did put in, want you to have the side effects, because a lot of what we do in the pulmonary hypertension clinic is work with patients to get them on these drugs and keep them on it. So it's learning how to manage the side effects that they may have initially, but will go away in most cases the longer they've been on drug. So in the current era, we use double or triple combination therapy. Most of our patients will be on at least medications from 2 pathways, if not 3. In the event that they do not respond to medical therapy, lung transplant is an option for end-stage pulmonary hypertension, which is refractory to therapy. One clinical trial that I think was notable is called the Ambition trial. And this was published in the New England Journal in 2014. And this trial actually marked a change in how we treat these patients. Prior to this study coming out, we would start a patient on perhaps a PDE5 and then monitor them a month to 3 months later. If they weren't improving, we'd add another medication. In the Ambition trial, we looked at combination therapy with ambrisentan, the ERA, and tadalafil, the PDE5 inhibitor, and compared that to tadalafil plus placebo, and then ambrisentan plus placebo. What we found was that the ambrisentan plus tadalafil group had clinically significant lower risk of clinical failure events. And those included death, hospitalization for PAH, slow disease progression, and obviously unsatisfactory long-term response. So this was pivotal because now if we have a naive or new patient, we will start them on, depending on what their functional class is, on an ERA and a PDE5. We have other studies looking at, for example, macitentan and tadalafil, which have similar results. In terms of patients who have severe PAH, functional class 3 and 4, we will use prostacyclins. And much of our data from some of our registries shows that prostacyclins are just not being used enough even to this day in pulmonary hypertension. We do have mortality data with epoprostenol, and you'll see from 1995. And the reason we don't have more mortality data was just it was not ethical to randomize these patients to placebo any further. So the prostacyclins are a mainstay of therapy for us, and they also can be used as rescue therapy if somebody comes in class for heart failure. We do have, as I mentioned, selexipag, oral prostacyclin analogs, which are available, but to date, those have not been effective in patients who need more of a rescue therapy. We still use them, just not in these really sick patients. So many of you may have practiced, as I did, with both inpatient and outpatient management. So I wanted to put in, what are the indications for hospitalization in these patients? It's amazing with close follow-up and with their pulmonary vasodilator therapy that the patients actually do very well, and most are at home. But there may be times when they need to come in. So the newly diagnosed patient with decompensated right heart failure, or if their oral diuretics are no longer working, we often need to bring them in for a tune-up. We used to start all our patients on parenteral prostacyclins in the hospital, but for those patients on sub-Q, they can be started at home. And certainly respiratory failure would be an indication for hospitalization. And then a big thing is issues not related to PH, because these patients are extremely high surgical risk. They should have any surgery, even an elective surgery, at a center with experienced cardiac anesthesia. On the right side of your screen, I have a very small study out of France, and it holds true today, is that these patients, and I think as providers, when we get a patient with pulmonary hypertension, we all are kind of tense because we know that they can change their status on a dime. This small study looked at triggering factors for RV failure in the inpatient setting. It looked at about 46 patients, and then 19 of those triggering factors were identified. What I want to point out is that for inpatient mortality, infection is the strongest predictor of death. And it occurred in this study and has been replicated in others. So we work actively, if patients are admitted, to avoid hospital-acquired infections. Some other triggers were pneumonia, arrhythmias, both rapid and slow. Withdrawal of their therapy or withdrawal of diuretics can be very dangerous because the patients need these therapies. If they're hypotensive, then we need to support them hemodynamically. I use this information both as an inpatient and outpatient nurse practitioner because if we understand what are some of the risk factors for in-hospital mortality, we can be aware of that as we're taking care of the inpatients, but also keep an eye on it on the outpatient side. So in this study from Campo, CTD, PAH versus IPH or other associated conditions, those patients are at higher risk for bad outcomes in general, but especially when they get hospitalized. Systemic hypotension, that is letting you know that the patients have impaired cardiac output to a certain degree. Hyponatremia, and here a sodium less than 136 is associated with poor outcomes. So we have to keep an eye on the sodium. And then need for mechanical ventilation. As much as possible, we try to avoid mechanical ventilation in patients with pulmonary hypertension. We can do it, but we know it can worsen pH, especially if we're using high PEEP. So it has to be done in a very experienced center if needed. So Jonathan mentioned, I've always been interested in quality of life in these patients, despite their chronic illness and their knowledge of that they have a non-curable illness. This patient population is really amazing. And so they're so grateful for any care that they get. So I love doing the quality of life research and understanding how to help them more cope. This particular study came out in 2016 when macitentan, one of the ERAs, was approved. And it showed in a subgroup analysis that MACI improves health-related quality of life for patients with PAH. And here patients were administered the SF-36. And in this particular trial, they were given placebo, macitentan 3 milligrams a day, and macitentan 10 milligrams a day, the latter of which was actually FDA approved for use. When we look at these domains, which include physical functioning, mental health, vitality, this is all from the SF-36. In these 10 domains, patients only, all patients on placebo had worse quality of life as compared with patients on macitentan, with the exception of their physical role. So,
Kathy, this is
yes.
Jonathan. We are about time.
Oh, okay. Thank you. I had a timer on because we started late. So let me just finish up here. In summary, PH is a progressive condition with substantial morbidity and mortality. Diagnosis requires a high index of suspicion for patients with unexplained shortness of breath. And I feel that's where we come in as healthcare providers to really think outside the box. Thank you so much. I have my email listed here, and I'll just cut it there for now. Thank you.
All right. Thank you, Kathy. I'm going to, I see from Liana, there are no questions, but I wanted to see if someone is still typing for any questions for Kathy. Michelle, did you have any specifically sent to your chat window?
Hi, Jonathan. I actually have a question, if you don't mind.
Yes, please go ahead.
Thank you so much. Hi, Kathy. Very great presentation. You know, I'm kind of very impressed because you mentioned that fen-phen used to correlate with pulmonary hypertension. And I was kind of wondering, is there any association with phentermine and pulmonary hypertension? Because, you know, I've noticed that a lot of cardiologists prescribe phentermine for weight loss. So are we actually doing more harm than good?
That is an excellent question. And actually, there's no association with phentermine. So that can be safe. But we still have to assess patients for the prior formulation of fen-phen. The other thing that I just would like to add to that in terms of drugs and toxins is that methamphetamine, as I mentioned, it's a widespread problem. And we see, especially in Northern California, the UCSF program has an extremely high patient population who have been meth users. Our patients often come to us who have use other types of amphetamines, such as Adderall. And when we talk about methamphetamine, we're really talking about the drug on the street, and Adderall is safe. There's no link with that medication. And there's no other anorexogens that I'm aware of that are being currently prescribed that could cause PH. I hope that helps answer your question.
You did. Thank you.
Thanks.
Thank you, Kathy. Thank you, Simona. Anyone else? All right, hearing none. Kathy, for me and for others, I think you took us through time travel. I'm looking at your bio and say 35 years. I feel like I've been walking through the halls, being at the bedside, going through, your explanations of each case by case. Something tells me you must be a good storyteller. Right. Going through each of these cases, I mean, what an immense experience that you could put it by WHO subgroups, categories, and what's applicable. I mean, for those who work particularly in this group of patients, I hope they were listening and taking down notes, because every clinical case and what is applicable and what is not, and the nuances to it. Thank you for walking us through that. Now, quickly to run down that.
You're welcome.
Dyspnea on exertion and fatigue, making sure that's there. And if you find all your tests are negative, make sure you go through the gold standard right heart cath, right? And look for the right heart failure. Yes, yes. And well, in case you're looking for it's not Viagra, you're not going to get passed through it as for sildenafil, right? And that's in particular. So, and the entry test being echo, VQ scan, and pulse ox, right? Okay. And anything else you would add as a parting comments, Kathy, before I'm going to let the
I would. One of the things with, if you suspect PAH, no matter where you practice, I highly recommend referring your patient to a pulmonary hypertension center. And the reason for that is multifold. But number one, the PH centers know how to get these medications for the patients. And generally, the programs have the resources to monitor the patients. This isn't something that can be easily done from private practice. I know at UCLA, we have really worked on our philosophy of co-management. We need the cardiologist, we need the PCP to join us. So it's a co-managing situation. And then just lean on those consults, because these patients can be extremely difficult to manage, especially in the inpatient setting, even for a non-related issue. Patient with PH breaks a leg and they have to go to surgery. You need to have a PH consult to guide that anesthesiologist or to transfer them to an appropriate center.
Right. Thank you, Kathy.
You're welcome.
Right. And we have two more exciting topics. And if you're not energized by now, you got two more, or to even more, give you more energizing topics on the way. So it's 10:06 now. We want to be meeting in 5 minutes. So 10:11, we're going to come back here and we'll start with the next topic. All right. We'll see you all shortly. The rate that approaches about 80% in men and 65% in women. And as we know, as individuals advance in age, the survival rate is higher. So then the number of patients with chronic heart failure also extends. All right. So I wanted to invite Jocelyn, who's going to speak on this topic. She's a pharmacist, PharmD from Cedars-Sinai Medical Center. Dr. Jocelyn Chang obtained her Doctor of Pharmacy degree from the University of Washington School of Pharmacy in Seattle. She completed a postgraduate 1-year residency in pharmacy practice at the University of Washington Medical Center, and then completed a postgraduate residency, 2-year residency in cardiology pharmacy practice at the University of Southern California of Pharmacy. Following her completion of postgraduate residency, she's been working as the clinical heart failure pharmacist at Cedars-Sinai in LA. All right, Jocelyn, over to you. We'll look forward to hearing from you.
All right, thank you. I believe you kind of gave a great introduction on heart failure and just why it's such an important disease state for all of us to learn about in order to better manage our patients. All right. Okay, so I just wanted to start with, I have no disclosures, or my disclosures that I have no conflicts of interest to disclose. In terms of learning objectives, I hope by the end of this session that we'll be able to discuss a newly proposed universal heart failure definition and classification, describe the rationale indications for guideline-directed medical therapy, or GDMT, used in heart failure management, evaluate evidence for newer heart failure therapies, and be able to develop patient-specific heart failure GDMT and monitoring plans for your patients. So let's start with heart failure, which Jonathan had already kind of gave an intro to. So heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. So basically, the pump of the heart is not meeting the demands, the metabolic demands of the body. And again, Jonathan alluded to just the very grim prognosis and epidemiology of heart failure. Approximately 6.2 million US adults have heart failure. Having heart failure has a very grim prognosis where at 1 year, about 80 to 90% survive. And at 5 years, only half of those patients survive from their diagnosis. And at 10 years, only 10% of heart failure patients survive following their diagnosis. Approximately, there are 1 million heart failure hospitalizations per year, and of the 1 million, 20% are from new heart failure diagnosis, so 80% are the recurrent heart failure hospitalizations that is very challenging to manage. And again, the overall cost of heart failure is quite exorbitant. It's about $43 billion just in 2020, and it's projected to be even higher, $70 billion by 2030. So the current heart failure classification that you might be familiar with is that first we distinguish patients based off of their ejection fraction, so the percentage of blood that is leaving the left ventricle. So the HFrEF group would be the heart failure patients with reduced ejection fraction, and their ejection fraction is less than 40%. And then there's the heart failure patients with preserved ejection fraction, where their ejection fraction is measured at greater than 50%. We also use the ACC AHA heart failure stages, which basically describe where the patient is in terms of their heart failure diagnosis by describing their structural heart disease, the status of their structural heart disease, as well as symptoms that they may have. And then we have a New York Heart Association functional class that helps to describe patients in terms of what their functional capacity is in terms of their symptoms of heart failure. So, oops, going back one slide. So the current limitations with the current heart failure definition is that it's not essentially applicable to all heart failure patients. If you saw from the previous slide, there's a group of patients that are kind of in the middle. Well, what about the patients who have ejection fraction between 40 to 50? Also with other uncommon, less common causes of heart failure that we can't just wrap up into HFrEF or HFpEF group. And there's also significant heterogeneity in diagnosing as well as some of the clinical features across the world. So different societies have different diagnostic criteria, and it just makes things a little bit more challenging and vague, and a lot of things are not consistent when we're looking at heart failure management as well as research. You'll see that the inclusion criteria for a lot of clinical research is very varying in terms of what is the right EF cutoff for a certain population that we're looking at. And so it's leading to a lot of persistent deficiencies and helping us implement heart failure GDMT. And it really causes a lot of confusion for the stakeholders involved in heart failure management. So the patients don't really understand their disease state. The people who bill for heart failure don't understand what the difference is between HFrEF and HFpEF, and the in-between. Primary doctors may also be confused as to what type of heart failure patients might have. So this is kind of why there was a strong pull to come together and develop a new universal definition of heart failure. So this was endorsed by the Heart Failure Society of America, Heart Failure Association of the European Society of Cardiology, as well as the Japanese Heart Failure Society. So in 2020, they provided a consensus statement on what should be the universal definition of heart failure. And their goal was essentially to make this simple, objective, comprehensive, that it's also sensitive and specific to label somebody with heart failure, and also make it universal across all guidelines through different countries like European Society of Cardiology, as well as HFSA and ACC AHA, as well as among clinicians and researchers, and also to help us improve our performance measures and optimizing our treatment strategies. So this diagram is also on the next slide. So essentially, the universal definition of heart failure is that it is a clinical syndrome with current or prior symptoms and signs that are caused by a structural and or functional cardiac abnormality, and also corroborated by at least one of the following, and that is elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. And then they also emphasized on the stages, talking about the patient's symptoms and where their current stages in terms of their structural heart disease. So it's very similar to the ACC AHA stages, where stage A is patients who are at risk of developing heart failure. Stage B is those patients who have some evidence of structural heart disease or abnormal cardiac function. So these patients would be labeled as pre-heart failure. And then our stage C are those patients that do have structural abnormalities and are symptomatic heart failure patients. And then stage D is our advanced heart failure patients who have very severe symptoms and not tolerating heart failure GDMT and need to be considered for advanced therapies. The new definition and classification system included additional ejection fraction cutoffs that we did not have previously. So we still have the HFrEF, which is an EF of less than 40%. We have the heart failure with mildly reduced ejection fraction. I don't know how people pronounce it. Sometimes they say HFrEF or HF mid-range EF, but it's the group that has an ejection fraction between 41 to 49. We have our HFpEF group, which has their ejection fraction greater than 50%. And we also have a category for patients who were previously considered maybe heart failure recovered with the heart failure improved ejection fraction, where they previously had HFrEF, but after medications, their ejection fraction is now greater than 40% because they had great response to therapy. So essentially, the language does matter, and the authors of this universal definition and classification system really wanted to emphasize that we should change the way we label patients in terms of, are they stable heart failure? Because this might make clinicians feel like, oh, the patient's stable, I don't have to do anything anymore, as opposed to using the term persistent heart failure, as in what else can I be doing for my heart failure patient, can I up titrate my dose to a target level? So it's just something to work towards. I think the semantics will help change our clinical practice in managing these patients. And then secondly, not calling these patients recovered heart failure patients when their ejection fraction goes from less than 40% to greater than 40%, and instead name it as heart failure in remission, because there is data to show that patients with recovered EFs actually do better and don't relapse when they come off their heart failure GDMT. So it's kind of like very similar to managing oncology patients. You know, once we achieve remission, we're not going to pull off on all chemotherapy for the patient. So it's kind of keeping those things in mind. So when we're managing heart failure, it's very important to understand the cause and etiology of the patient's heart failure, because some of these things can actually be treatable and reversible while other things may not. So ischemic heart disease and hypertension are probably one of the more common causes of heart failure. We can also have viral, alcohol, substance abuse, drug-induced, stress-induced like Takotsubo cardiomyopathy, or we can have, unfortunately, maybe unmodifiable causes of heart failure, such as hypertrophic cardiomyopathy, valvular, familial, peripartum, amyloidosis, sarcoidosis. But essentially, it's important to understand what is causing the heart failure and try to reverse that as our initial step in managing these patients. The second part is really understanding heart failure pathophysiology. Understanding pathophysiology will help you understand where the medications really come into play. So when a heart takes a hit, maybe it was a massive heart attack and there's a reduction in cardiac output, this will lead to the body to try to compensate, and it leads to activation of the sympathetic nervous system, activation of the renin-angiotensin system or RAS system. So when the sympathetic nervous system is activated, this will increase the heart rate, increase the inotropy. This leads to left ventricular hypertrophy, and in the long run can lead to a burned out heart, and it just turns into this vicious cycle of heart failure. And then when the RAS system is activated, this leads to increased levels of angiotensin II, which leads to vasoconstriction, increasing the preload and the afterload. Essentially, the heart has to pump a lot harder to overcome the pressure to move blood forward to meet the demands, the oxygen demands of the body. So it's just this negative remodeling that just becomes cyclical. So we'll see how our medications, such as beta blockers, can help blunt the activation of sympathetic nervous system, and some of the RAS agents that can help augment the RAS activation system. So I'm going to do my best to try to help demystify this HFrEF medication management, because we have so many wonderful agents available. It's figuring out where do they fit in. So it's important to understand where your patient is in terms of their stage of heart failure. So we talked about our stage A patients. So these patients who are at risk, essentially they should be treated for their underlying causes and risk factors for heart failure. And that might be their hypertension, diabetes, hyperlipidemia, with ACEs and ARBs. And then our stage B patients are the pre-heart failure patients who have some evidence of structural heart disease, should essentially be on an ACE or ARB or an ARNI at this point. And then in some patients, they may be warranted for a beta blocker in case maybe they have coronary artery disease as well. Our stage C patients is basically going to be candidates for a lot of the heart failure GDMT that we have available, which usually they'll be on an ACE, ARB, or ARNI, or beta blocker, plus or minus some of the other medications, depending on what their patient's specific characteristics are. And then our stage D patients, unfortunately, are no longer responding to our medications and should be considered for advanced therapies such as mechanical circulatory support, heart transplantation, or hospice. So this is kind of how I envision HFrEF stage C management. Essentially on the top, we have the 4 pillars of heart failure GDMT. We have our RAS blocking agents, the sacubitril valsartan or an ACE or ARB. And then we have beta blockers, aldosterone receptor antagonists, and our SGLT2 inhibitors. And most of these patients will be requiring some form of diuretic for symptom control. And then depending on patient characteristics, these patients may be on some of the other agents that might help them. So this is a really nice diagram that you can always refer to. This was published in JACC recently, and it was essentially published as an interim guideline from the ACC to help provide guidance for clinicians on how do you manage your HFrEF patients with some of the newer therapies that are available. And essentially it provides guidance on where does SGLT2s fit into the picture, because the previous guidelines talked all about our sacubitril valsartan and ivabradine therapies. So essentially, if we follow this algorithm, all patients with stage C heart failure should be on an ARNI or an ACE or an ARB and a beta blocker and diuretic agent if they're symptomatic. And then it kind of goes into they should be on an aldosterone receptor antagonist and et cetera, based off of their criteria on the third row here. One thing to keep in mind is that there are ongoing heart failure registries analyzing how well we are doing with our GDMT optimization in our patients. And Greg Fonarow from UCLA has actually shown that we're not doing that great. You know, we have all these great data and it's exciting to see things published in the New England Journal of Medicine, but we're barely hitting 50% in terms of getting patients on RAS blockade as well as beta blockers. So maybe we should be working on optimizing those therapies before we're resorting to these new, cooler, kid on the block medications. So that's why I kind of highlighted this box here, that let's focus on the 4 pillars of GDMT. So I'm going to start diving into our heart failure pharmacology, and just to help you be able to gain more confidence in terms of being able to prescribe the right medication for your patient. So starting with the ARNIs, or angiotensin receptor blocker neprilysin inhibitor, it's a mouthful, which the only agent available in this category is sacubitril valsartan, or the brand name is Entresto. It is indicated in patients with ejection fraction less than 40%, less than or equal to 40%, and NYHA class 1 to 4, so symptomatic or asymptomatic. And ARNIs have been shown to help reduce mortality and morbidity, as well as heart failure hospitalizations over the previous standard of therapy that we had at the time, which was ACE inhibitors and ARBs. So the mechanism in how ARNIs work is that it's a 2-component medication where valsartan is the ARB, which helps to block the negative effects of angiotensin II. Sacubitril is a neprilysin inhibitor, which prevents the breakdown of natriuretic peptides and essentially helps to promote vasodilation as well as natriuresis, and essentially blunting the neurohormonal remodeling. some adverse effects that are common with this medication is hypotension, acute kidney injury, and hypo or hyperkalemia. So it's important to monitor your patient's vitals as well as renal function and serum potassium after patients are initiated on therapy, as well as up-titrated probably about a week or two after these changes are made. ARNI should not be prescribed in pregnant patients, any patient with a history of angioedema, whether it's hereditary or due to prior ACE inhibitor use, and also should not be used in conjunction with aliskiren in diabetic patients. So the supporting literature for ARNIs and why that it is the preferred initial strategy over an ACE or an ARB is that the Paradigm heart failure study showed that there was an absolute reduction of 4.7% in cardiovascular death and heart failure hospitalization in the ARNI group compared to the gold standard, which is enalapril, and essentially kind of blew the ACE inhibitors and ARBs out of the water at that point. And then additional trials that came out after Paradigm gave us a little bit more confidence in terms of initiating ARNIs after a recent acute decompensation, because the patients included in Paradigm were mostly outpatient, NYHA class 2, maybe some 3, versus Pioneer was more patients who were NYHA class 3 or 4, so definitely more symptomatic, and showed that it was effective at reducing BNP levels, just because that was their primary endpoint that they had established, which BNP levels essentially serve as a surrogate for the patient's heart failure status, because it reflects the stretch of the left of the ventricles. PROVE-HF was another study that showed that starting ARNIs without having to trial patients on an ACE or an ARB was shown to be tolerable, as well as effective at reversing cardiac remodeling, where they actually saw an improvement in ejection fraction on an average of 12% within a year. So we have a lot more data to help us confidently and more reassuringly prescribe ARNIs over ACE and ARBs, which have pretty much been the mainstay of heart failure stage C management. So when we're prescribing ARNIs, we want to make sure that we have a 36-hour washout period to or from an ACE inhibitor. This is important because this will reduce the patient's risk for angioedema. It's thought to be related to maybe too high levels of bradykinin, because the neprilysin inhibitor prevents the breakdown of bradykinin, and so does the ACE inhibitor. So it's okay with sacubitril to be combined with an ARB, because ARB is a little bit further down the pathway where bradykinin levels are not affected. So the 36-hour washout is a must. The initial dose depends on what the patient's prior ACE inhibitor or ARB dose was, as well as maybe their hepatic and renal function. The goal is to up-titrate their doses to the target dose of the highest dose, I'm just blinking here, 97-103 adds up to 200 every 2 weeks. We want to up-titrate the doses every 2 weeks to try to get to target. And then also we want to be cautious in evaluating BNP levels, because the sacubitril prevents the breakdown of BNP. So just because your patient's BNP level is greater than 5,000 doesn't mean that they're in acute decompensated heart failure. It's probably an effect of the sacubitril. But this reassuringly, the NT-proBNP levels are not affected. So if your facility has the capacity to run those levels, try to order that instead of the BNPs. And one thing to keep in mind is that the ARNIs may require prior authorization. It's gotten a lot better over the years, given all the, robust data that we've seen when using this medication, but it is something to keep in mind before switching patients over, starting them, because the costs can be quite high. So let's say if your patient cannot obtain an ARNI or tolerate the ARNI, we can still use our ACEs and ARBs in the same fashion that we've done before. It has been shown to reduce mortality, morbidity, as well as heart failure, hospitalization. The ACE inhibitors essentially prevent angiotensin II from being produced, versus the ARBs prevent the receptors, prevents the angiotensin II at the receptor site. But both of them work in helping to reverse neurohormonal remodeling. Very similar adverse side effect profile as ARNIs, maybe less hypotensive causing than ARNIs, but also can cause acute kidney injury. Sorry, not hypokalemia, but usually causes hyperkalemia. And so we do want to monitor patients for these, and then the dry cough that can develop on patients taking ACE. These agents should not be used in pregnant women. ACEs should not be used in a history of angioedema, and also should not be used with allospirin in diabetic patients. So the benefit has been demonstrated to be a class effect for all ACEs and ARBs across the board. The guidelines do recommend ACE inhibitor is preferred over ARB, and this is mostly because there's more data and literature to show benefit with ACEs inhibitors. There have been very little limited head-to-head studies between the two. It's just the data with the ACE inhibitors is more robust. So that's why the guidelines do recommend ACE inhibitors first. And again, if the patient develops an intolerance, such as angioedema or cough, an ARB can be considered. The other times that we do consider ARB first is if we are planning to switch the patient over to an ARNI and don't have to watch out for the 36-hour washout period. So maybe we're waiting for some financial authorization to go through. So we'll try to use the ARB so that it can be an easier switch to the ARNI at a later time. When we want to start at the lower doses and titrate up every 2 weeks to the maximum tolerated dose or the target doses. The serum creatinine will probably increase. It may or may not, but most likely it can increase up to 0.3 mg per deciliters after patients start, which is just a sign that the medication is working, but not harming the patient. And if you see a greater rise in the creatinine after a patient starts these two, one of these agents, is to really consider, okay, there really might be an acute injury going on. So this is just for reference if you have access to the slides later in terms of the starting doses for ACEs and ARBs and what target doses we're trying to achieve. They're also listed in the guidelines. I think it's helpful to try to achieve the mean doses that were achieved in the heart failure trials, which is why I add the fourth column. So then the next agent that patients should be on is beta blockers. And essentially all patients with stage C HFrEF should be on ARNI, ACE, ARB, one of those three, as well as the beta blocker. Beta blockers have been shown to reduce mortality, morbidity, as well as heart failure hospitalizations. They essentially block beta receptors, and this helps to blunt the sympathetic nervous system activation and ultimately to reverse neurohormonal remodeling. Adverse side effects we watch out for is hypotension, bradycardia, fatigue, and sometimes impotence in males. And we just need to monitor the patients for their vitals and their symptoms to see how they're feeling. So beta blockers have been proven to improve ejection fraction on an average of 10 to 15%. So that's kind of one counseling point I share with my patients to encourage them to take their medications. Beta blockers can be continued in patients who present with acute decompensation if they're hemodynamically stable, of course. So these are your warm patients who are perfusing adequately. Of course, if you have someone in cardiogenic shock, you want to stop the beta blocker and consider some inotropes. Carvedilol is a beta selective beta blocker, which has been shown to improve insulin sensitivity. So maybe an agent you would consider for a patient who also has diabetes as a comorbidity, and metoprolol actually worsens insulin sensitivity. So maybe you want to avoid that medication in a diabetic patient, but might be a beta-1 selective beta blocker might be useful in a patient who has borderline blood pressures, systolics in the 90s, where you're worried about the alpha blockade from carvedilol maybe dropping them further. So that's kind of one strategy we use in the clinical setting. And then also it's really important to counsel the patients that, when you initiate the beta blocker, most patients tend to feel worse initially, but as you keep taking it and the body acclimates to the medication, they should feel better in the next few weeks. But they shouldn't stop taking their medication. So it's really important to keep in mind that the benefits with beta blockers is specific to carvedilol, metoprolol, succinate, and bisoprolol only. It's not a class effect. It's important to start at the lower initial doses and titrate up every 2 weeks until the maximum tolerated dose or the target doses. So you can see that bisoprolol and metoprolol are both beta-1 selective, so might be more beneficial in your patients with borderline blood pressure. And then if you have your patient with robust blood pressure, carvedilol might be the other agent of choice, or if your patient has diabetes, to help improve their insulin sensitivity. So once patients are on an ARNI or ACE or ARB or beta blocker, they should be considered to be on an aldosterone receptor antagonist. And these are indicated in patients who are have ejection fraction less than 40%, as well as some symptoms, so class 2 to 4. They've been shown to help improve mortality, morbidity, as well as heart failure hospitalizations. They block the negative effects of aldosterone, which leads to vasoconstriction, to help augment neurohormonal remodeling. Common adverse side effects to monitor for is hyperkalemia, acute kidney injury, sometimes causes GI symptoms, so need to be monitoring closely for that. Gynecomastia occurs in patients in about 10% of patients receiving spironolactone. And hypotension is listed in the package insert because we do use these agents to treat hypertensive patients, but at the doses that we use for heart failure, it's unlikely to cause hypotension. And these agents should not be initiated in patients who are pregnant or have serum creatinine of 2.5 or higher in males or 2 in females, or if they have an eGFR less than 30 and a baseline potassium of 5 or greater. So the benefits has been demonstrated as a class effect. We only have 2 available, which is spironolactone and eplerenone. These medications also conveniently have a potassium sparing effect, which might help to reduce patients' need for potassium supplements. And this leads to happy, compliant patients. So this is also another counseling point I share with our patients to help them take their medication. And again, we do want to start at the lower initial doses and try to titrate up every 2 weeks until the target dose. So the fourth heart failure GDMT, which is kind of like the latest class of drugs that have come in our heart failure armamentarium, and it's the SGLT2 inhibitors. Let's see, and so the SGLT2 are essentially sodium glucose linked transporter that are located in the proximal tubules in the kidney. There are some SGLTs, one in essentially, and it can be in the gut, but usually the SGLT2 is predominantly the one that reabsorbs the glucose. So the SGLT2 inhibitors help to prevent sodium glucose reabsorption. And essentially, this is a serendipitous story where the EMPA-REG Canvas declared TIMI 38 were required to report cardiovascular outcomes to the FDA for all new diabetic trials, and essentially serendipitously found that there was a profound reduction in heart failure hospitalizations, as well as cardiovascular death in type 2 diabetic patients. So this really leads us to further trials that led to further trials evaluating SGLT2 in heart failure specific patients. So the mechanism for SGLT2 and the benefits in heart failure is still unknown, but we think that SGLT2 inhibitors provide such profound benefit in our patient population just from the natriuresis aspect, where it's helping to reduce preload and afterload and providing benefit to the heart in that aspect, as well as potential metabolic antioxidant effects through the getting rid of the excess glucose in the body, but still not clear. So I wanted to highlight just the two major heart failure studies that evaluated SGLT2 inhibitors in heart failure patients. And these were patients who had diabetes or didn't have diabetes. So that's important to note that there's some kind of other mechanism that's working that's outside of treating hyperglycemia. So we have the DAPA-HF, which evaluated dapagliflozin, and then the EMPEROR-Reduce, which evaluated empagliflozin compared to standard of therapies. So most of the patients were older than 18, ejection fractions less than or equal to 40%, NYHA class 2 to 4 were included, and they had to have some level of BNP elevation to demonstrate that these were truly heart failure patients. Systolic blood pressure cutoffs anywhere from 90 to 100. Their eGFR cutoffs were slightly different. It was 30 in the dapagliflozin group, 20 in the empagliflozin group. And just to keep in mind that type 1 diabetes patients were excluded from this study. That is pretty much it for exclusion criteria. So in terms of who was included in these trials, so the mean age was about 66, 67, most predominantly male. Their eGFR was around 60s, and about 40 to 50% patients had type 2 diabetes, and about a little over half were had ischemic cardiomyopathy or coronary artery disease as their cause of heart failure. The mean ejection fraction was around 30% in the DAPA group, 26% in the empagliflozin group. Majority of the patients were NYHA class 2 to 3, probably more class 2, so are stable, less symptomatic patients. And then you can see the baseline heart failure GDMT, which is important because I like to emulate background medical therapy and initiating new therapies based on how the trials were done. So this is pretty promising, where almost 90% of our patients were on the first two important pillars of heart failure GDMT, are ARNI, ACE, ARB, and beta blocker. And then there was about 70% of our aldosterone receptor antagonists. And again, majority of the patients were on some form of diuretic because they have symptoms. So in terms of looking at the heart failure primary outcome, I essentially both of the SGLT2 inhibitors show a reduction in their primary composite outcome, was essentially a combination of looking at cardiovascular death as well as worsening heart failure or heart failure hospitalization. In terms of looking at renal outcomes, so it's similar to the ACEs and ARBs. Patients' renal function will decrease initially when they're started on the therapy. And this has to do with a reduction in the glomerular, the pressures in the glomerular filtration. But over time, you can see that the renal function is actually preserved compared to the patients who did not receive the SGLT2 therapy. So essentially the common theme was you'll see worsening of the renal function initially, and this is expected, but over time you can see that there was preservation in the renal function. Okay. And then I also just wanted to highlight just a newer study that was published because the prior DAPA-HF and Emperor Reduced looked at mostly NYHA class 2 and 3 patients, that the Soloist was a trial that looked at SGLT2 SGLT2s in patients who had a recent heart failure decompensation. So they looked at sotagliflozin in patients starting this therapy within 3 days of discharge or just prior to discharge. And essentially, we see the same type of benefit where there was a reduction in total cardiovascular death and hospitalization for heart failure when patients were initiated early on after their heart failure hospitalization. So essentially, patients should be on SGLT2 inhibitors after they've been on at least one of the 3 RAS blocking agents, as well as a beta blocker, unless they have a comorbid condition like diabetes. Maybe patients would be on that to treat their diabetes. And it's been shown to help reduce mortality as well as morbidity, as well as heart failure hospitalization. We talked about the mechanism. So in terms of adverse effects, want to be monitoring for the renal function. There were some genital urinary infections, more UTIs and yeast infections in these patients. Not a whole lot. The percentage was still low, and UTIs are fairly easy to treat, but essentially counseling patients on good hygiene is important. And then it can also cause rare cases of Fournier's gangrene, and then also hypovolemia because of the diuresis and natriuresis that it promotes. So monitoring your patients for that, and also for potentially ketoacidosis in your patients, your diabetic patients primarily, who are on insulin or sulfonylureas. We should not be using the SGLT2 inhibitors in patients on dialysis. Other things to keep in mind when you're managing patients with SGLT2 inhibitors, that if they're going in for a planned surgery, that SGLT2 inhibitors have an FDA label warning to stop it 3 days before the surgery if they are diabetic. This doesn't apply to non-diabetic patients because their glucose balance is usually intact because of the risk of developing euglycemic diabetic ketoacidosis. The patient can resume the SGLT2 inhibitor when they resume their normal intake. And other thing to keep in mind is to also have the patient watch their blood sugars, especially if they're a diabetic patient using insulin or an insulin secretagogue. They might need to adjust some of that when they're initiated on these therapies. So, and here is the dosing for reference for the SGLT2 inhibitors. This next medication, so we talked about the 4 heart failure GDMT, basically the 4 pillars of heart failure GDMT. Now I'm going into some agents that might be considered in some select patients based off of their patient specific characteristics. So Vericiguat is a novel oral soluble guanylate cyclase stimulator. It increases sensitivity to nitric oxide and enhances cyclic GMP production, which leads to smooth muscle relaxation and vasodilation. Vericiguat was studied in the Victoria HF trial, which was a phase 3 randomized double-blind placebo-controlled trial, and included patients who had EF of less than 45%, class 2 to 4 heart failure, or class 2 to 4 symptoms, and they had to be recently hospitalized for heart failure or have received outpatient IV diuretics. So this is kind of a sicker group than maybe the previous agents we talked about. And then patients who had blood pressure less than a systolic less than 100, or were receiving a long-acting nitrate or sildenafil or one of the PDE5 inhibitors were not included in this study. So the Victoria trial showed that Vericiguat had a 10% reduction in cardiovascular death and heart failure hospitalization over the mean follow-up of about 10, 11 months, and that was statistically significant. It's important to note that the primary endpoint results were mostly driven by the heart failure hospitalizations and not the cardiovascular deaths. So when we tease out the secondary endpoints, that the cardiovascular death did not reach statistical significance. At baseline, in terms of heart failure GDMT, over 90% of patients were on a beta blocker, 70% were on an ACE or an ARB and aldosterone receptor antagonist, 15% were on an ARNI, 6% were on a Vabradine, and only 3% were on an SGLT2 inhibitor. So this trial was essentially kind of ongoing at the same time as when the SGLT2 inhibitors were studied. So it looks like the effect was pretty consistent across all the subgroups, including the patients who weren't on an ARNI. That's something to keep in mind. And so for Vericiguat, I would maybe consider this agent in your more symptomatic heart failure patient that is still having symptoms despite being medically optimized on the 4 pillars of heart failure GDMT. And again, keep in mind that it's mostly patients who were recently hospitalized or had required outpatient IV diuretics. So Vericiguat did show mortality, morbidity, and heart failure hospitalization benefit. We talked about the mechanism. The side effects we wanted to be monitoring for is hypotension, because it does cause a significant vasodilation, as well as embryo fetal toxicity. So really making sure you're having a discussion with your patient that if there's any plans for pregnancy, that they should not be on this medication. And patients who might have a, concomitant diagnosis for pulmonary hypertension should not be on Vericiguat if they're receiving another soluble guanylate cyclase stimulator like Vericiguat. So I mentioned that Vericiguat can has risk to the fetus, so that patients of reproductive potential should be on some form of contraception while they're on therapy, and essentially for a month after stopping the therapy if they did choose to try to have children. Currently, there is no official REMS program like the pulmonary hypertension patients might have for this medication that I saw. So something to be looking out for, but doesn't look like you need to be REMS certified to prescribe. And then really monitoring for hypotension, especially for patients who are receiving other vasodilators, such as short-acting nitrates, and then keep in mind that those that were on the long-acting nitrates were excluded. And then the other thing to consider is the drug cost. Currently, it's about $700 a month. So we might want to consider other therapies with that have a little bit more robust data before resorting to such an expensive agent. And then I just wanted to highlight diuretics, because I'm sure we're using this in almost all of our stage C heart failure patients. The benefit is that it helps to improve symptoms only. There's no mortality benefit. We're preventing the sodium reabsorption in the loop of Henle to help patients urinate the excess water. It's important to monitor for hypotension, looking at the electrolytes. It can cause hypokalemia, hyponatremia, worsening renal function. It can precipitate gout. So monitoring for things, for those things. We have 4 loop diuretic agents available. Am I doing okay on time? I know we started late. I just want to make sure.
Jocelyn, probably another 2 minutes. Then we
Okay.
Yeah.
All right. I'll try to get through the slides in 2 minutes. So essentially, the furosemide, we're all familiar with. These are reference doses, less bioavailable than the other agents like torsemide and bumetanide, so might be more beneficial in your patients with right-sided heart failure or gut absorption. And ethacrinic acid should be reserved for patients with true sulfa allergies. Thiazide diuretics, you're familiar with metolazone and Diaryl or chlorothiazide agents, and essentially these are going to help augment our diuresis. And when the patients are on their maximally tolerated loop diuretics. So it's important to counsel the patients to take these booster pills 30 minutes before taking their morning loop diuretic for it to kick in. Big things to watch out for is electrolyte monitoring when patients are taking this medication. I don't think we have time to go over digoxin, but essentially the data for digoxin is that it helps to reduce heart failure hospitalization by helping with improving a little bit of cardiac contractility. When patients are on digoxin, it is important to be monitoring for levels, not for a target level in particular. I just wanted to make sure that prescribers are obtaining trough levels at least 5 to 7 days after starting a dose or making a dose change. And we just want to make sure that they're clearing the medication, that their level is less than 1. If it's undetectable, you don't need to increase the dose because there are studies to show that, there is increased mortality if levels are greater than 1. I just wanted to highlight the signs and symptoms of toxicity, which is nausea, vomiting, visual changes. I included the Van Gogh Starry Night because it was thought that he chewed digitalis leaves, and so the halos around the lights could have been digoxin toxicity. Avabradine, I'm sure you're familiar with, inhibits the funny channels to help reduce the heart rate. And this should only be prescribed in patients who are on all other heart failure, GDMT or whatever they can tolerate, are in normal sinus rhythm and have a resting heart rate of 70 beats per minute or higher. And unfortunately, the benefit is only to help reduce heart failure rehospitalization. Essentially, if we're comparing this therapy to digoxin, in terms of the cost benefit and the outcome data, I think this is why the uptake in using avabradine hasn't been as robust as it was for using the ARNIs. Isosorbide hydralazine should be considered in patients who are African American and are on all maximally tolerated heart failure GDMT and still symptomatic. Isosorbide hydralazine should be considered in patients who are also unable to tolerate an ARNI, ACE, or an ARB. And these 2 agents have been shown to help improve mortality and morbidity and heart failure hospitalizations just by helping with arterial and venous vasodilation. And then I just have these reference slides for you in terms of what doses to be prescribing. You do want to make sure that there is a nitrate-free interval of at least 10 to 12 hours. So make sure patients are taking it 3 times a day while awake, not Q8 hours. And then we usually don't use the fixed dose combination Bidil because it's more expensive and the patients still have to take it 3 times a day anyways. And then BID can be an option for patients if 3 times a day is just too much. So I hope that kind of summarizes medication management for stage C patients. We don't have time to talk about like the HEF mid-range or HEF-PEF patients, but I just wanted to highlight that for these patients, essentially treating the underlying cause is the main goal, using diuretics for symptom management. There is some data to suggest that ARNIs, spironolactone or eplerenone, SGLT2 inhibitors can help to reduce heart failure hospitalization in the HEF-PEF group, but we're just waiting on further guidance from guidelines. Just to quickly go over barriers to medication adherence, just consider medication costs, pill burden, medication side effects, and health literacy for your patients. So to help with medication cost, try reaching out to your pharmacies, submitting prior authorization, using Cover My Meds. Some of these other resources are super helpful. I love using Epocrates for formulary information. Walmart has most of the heart failure GDMT on their list. Using 90-day supply to reduce copays, mail order pharmacies, or even the manufacturer free trial coupon is super helpful to buy you some time to complete some of the authorizations. Simplify the regimens for your patients to reduce the pill burden. Deprescribe wherever you can for medications that are no longer beneficial or maybe causing harm to the patient. Switch the agents to alternative things like switching your lisinopril to the ARB if they have a cough, and also provide medication education in terms of what to expect. Don't really have time to go over the Medicare Part T donut hole, which is very challenging to navigate, but also want to highlight medicines we should avoid in heart failure patients. And these are medications that can cause sodium water retention, which are the non-steroidal anti-inflammatory drugs, the diabetes drugs, pioglitazone, rosiglitazone, steroids. You want to avoid non-dihydropyridine calcium channel blockers in low ejection fraction patients because it's a negative inotrope, and illicit drugs, stimulants like Adderall, and then pseudoephedrine just because it forces the heart to work harder. So in summary, we want to be evaluating patients in terms of what stage they are in their heart failure diagnosis, and go treat them from there. Essentially the patient should be on the four pillars of the heart failure GDMT, and then should be considered for the other agents that we had talked about based on their specific patient characteristics. And then that there are some therapies like ARNI, aldosterone receptor antagonists, SGLT2 inhibitors for the HEF-MEF or HEF-PEF patients to reduce hospitalizations. Are we doing post-test questions now or saving them for later?
I believe we're saving them for later in the interest of time, but I do have several questions for you from the chat, if that's
Sure.
Okay. The first one is, do you find benefit in switching to a different beta blocker if patients are having symptoms, particularly fatigue with beta blocker?
Yes, we will just try, like if patients are not tolerating metoprolol, sometimes we find some patients do perfectly fine on carvedilol. It's just starting at the lowest doses, so maybe carvedilol 3.125, and making sure that counseling the patient that they are going to feel terrible. It's not the best, but after 2 to 3 weeks, as they continue to take it, their body should adjust to it. So yeah, starting at the lowest doses and switching to an alternative agent is what I would do.
Great. And we have one more question. Thoughts on using Entresto or SGLT2 in patients with HFpEF who have congestion and need for large doses of diuretic, outpatient IV diuretics, or need readmission for heart failure symptoms?
Yeah, so as I mentioned, there was some studies such as the Emperor Preserved, as well as the Paragon study that looked at Entresto and HFpEF groups, and it unfortunately didn't show a lot of cardiovascular death benefit, but did show benefit in helping reduce heart failure rehospitalization. So if they're symptomatic and their insurance is able to cover the medications, and I would definitely consider those two agents.
Great, thank you so much.
Right. Thank you, Jocelyn. Thank you, Michelle. Is there anyone else who have any other questions? If so, put them in the chat. We could use it during Q&A session. Jocelyn, thank you so much for walking us through demystifying this completely for us. And I want to reference a couple of your slides for those who want to look up later. Is Jessup and Drons et al., that particular slide, and Maddox and et al., and the 4 pillars of the GDMT. And in particular, I wanted to say the language matters most. So it's persistent HF rather than stable HF. And then it's HF in remission rather than recovered. All right. All right. We have the next topic, and that is on anticoagulation therapies, updates on anticoagulation therapies. In cardiovascular conditions, when it is time for the patient to leave the hospital, think of a funnel. It comes down to now, the question is, how about the anticoagulation part? Who, when all the W's, who, when, where, how, is this patient eligible or not? Is this applicable or not? When, where? So those questions remain. So arterial and venous thromboembolism are the leading causes of morbidity and mortality around the world, prevalent both in high income, and there is a rise in incidence dramatically. It's increasing in the middle income and low income countries as well. The reported statistics on increasing number of vascular injury, MI, stroke, venous thromboembolism, and PE. That demands an evidence-based approach in making decisions. And that imposes heavily on first prevention and then the effective treatment as an important goal. With that, I'm going to invite Stephanie Yocum. Welcome, Stephanie. She is a nurse practitioner, board certified, with 20 years of experience in cardiology as a nurse practitioner. She's currently an electrophysiology nurse practitioner at UC San Diego Health, working in both inpatient and outpatient setting. Before, she has been working in electrophysiology, that is specifically for 17 years. Stephanie is involved in various societies of cardiovascular societies. She was involved in building a UCSD remote monitoring program. You know how important it is at this age, this time, and she has played a significant role in that aspect. Closely works with the radiology department and establishing a workflow for device patients needing MRI. She is co-author. She's a first author on 2 abstracts. Co-authored a book chapter that is a case-based device therapy for heart failure. She's an active member of Heart Rhythm Society, ACC, California Association for Nurse Practitioners, and Sigma Theta Tau. And she has presented her work in all these organizations. She's also an adjunct professor at San Diego State University, lecturing and precepting nurse practitioner students. All right, with that, Stephanie, take it on.
Thanks, Jonathan. I wanted to thank the committee today for inviting me to speak. It's an honor to follow all of these great talks. I'm sure at this point in time, everybody's kind of getting the look from the kids or the dog or their family members of like, let's go, let's get our Saturday started. Jonathan, get your hook out because I have a lot of slides to talk about and to go through. So we will get started. Here are my disclosures. For our objectives today, identify and classify the available oral anticoagulants. And I'm going to specifically focus on oral anticoagulation because we can get into antithrombotic agents, IV, injectable, those types of things. So specifically looking at oral anticoagulants. Discuss oral anticoagulation in the prevention of stroke related to atrial fibrillation, which is my bread and butter, which I spend the bulk of my day doing. Understanding the relative benefits and limitations of oral anticoagulation options, and then managing oral anticoagulants in the periprocedural period. I'm also going to cover a couple of other topics that we'll get through. Initially, I'll present the different available agents, and then we'll talk about how and when to use them. When we think about anticoagulation, and I'll have to give a shout out to Mary Hunsinger, I think she actually developed this slide for a talk that we had. As we've gone through the talks today, we've seen, the lipid management with how the liver synthesizes things and where along the continuum do all of our different agents for heart failure work. So when we talk about anticoagulation, we have to look at the clotting cascade. So I'm thinking in my talk today, and I'm like, okay, I'm the fourth speaker. We're all at home. It's Saturday afternoon. Do I want to like my first slide to be the clotting cascade? So I said no. So I think Mary and I developed this slide as a transition slide of showing fibrin forming essentially a clot on our slide or on the slide. And then I thought, this might be actually a better slide to look at because this is the goal that we're all hoping to get through, although here in Southern California, it's not very sunny right now. But this is a picture of the UCSD Scripps Pier down at the beach, beautiful sun, and might be a little bit softer. But nonetheless, we need to get to the clotting cascade. So when we look at formation of thrombus and need for anticoagulation, we're looking at intervening in different areas along this path to basically inhibit the formation of thrombus or emboli. So we have the intrinsic pathway, the extrinsic pathway, and the common pathway. And I'm not going to bore you with all of that, but it's important to note that there's a variety of factors that all sort of work together to form fibrin down here at the end of our sort of cascade. And when we talk about different anticoagulation agents, they're going to work at different areas along this continuum. So indications for anticoagulation, like I said, the one that I deal with most often is stroke prophylaxis for atrial fibrillation. When we're looking at preventing stroke related to atrial fibrillation, we use the CHADS-VASc criteria. I'll talk about that on the next slide. We also use anticoagulation for prevention of DVT or pulmonary embolism. We use it for post-op prophylaxis for people undergoing surgeries. Primarily, we think orthopedic surgeries to prevent venous thromboembolism. We can use anticoagulation post-MI to reduce the risk of death, recurrent MI, thromboembolic events, stroke, and then also LV thrombus. And then obviously in cardiac valve replacement, then there is potential for thrombus formation there. So we have to anticoagulate people around that time as well. Specifically looking at stroke prevention, anticoagulation as it relates to atrial fibrillation. The annual risk of having a stroke in somebody with atrial fibrillation can be as high as 8, even higher % per year, depending on their CHADS-VASc score. Atrial fibrillation strokes account for about 15% of all strokes, so it is a significant chunk. We assume that strokes related to atrial fibrillation result as a clot in the left atrial appendage, and we'll talk about ways that we can manage that non-pharmacologically later on. We know that they're effective. We know that they do better than placebo. And the important thing, and we'll talk about this over and over again this afternoon, or I don't know where we are, I think we're still morning, but is risk stratification. That's the biggest thing. Who do we anticoagulate? When do we stop anticoagulation? How do we work with other agents and other needs of these patients? So here's a example of the CHADS and the CHADS-2 criteria. When I have students coming from, San Diego State or wherever they're coming from to precept with me, in my clinic, I'm like, you need to know the CHADS-VASc criteria. We use this every day in analyzing our patients. And essentially what we're looking at is the risk of stroke associated with atrial fibrillation based on other risk factors that they have. So what is their risk factors other than having atrial fibrillation, and how do we make a decision? Do I need to put my patient on anticoagulation? Can they be on aspirin, which poor aspirin is really falling out of favor and we're not using a lot of it now, or can they potentially get away with nothing? So we look at the various factors, and if we're specifically looking at the CHADS-VASc, it's looking at congestive heart failure, hypertension. If you have if you're over the age of 75, you get 2 points. If you're diabetic, you get 1. Stroke, TIA, or other history of thromboembolism, it gets you 2 points. Vascular disease, so coronary disease, peripheral arterial disease, aortic plaquing gets you 1. age greater than 65 to 74, sex or gender, so being female actually counts against you when you look at the CHA2DS2-VASc criteria. And then we add up all of those points and assign a score to them. So CHA2DS2-VASc score of 3. And then we look at our guidelines, and essentially what the guidelines say is that if your risk of having a stroke outweigh your risk of having a bleed on anticoagulation, then you should be on oral anticoagulation. And the annual risk of having bleed sort of in large studies has been 1.8 to about 2%. So if your annual risk of stroke is greater than 2% per year, you need to be on an oral anticoagulant. And you can see if you look here at the CHA2DS2-VASc with the CHA2DS2-VASc score of 2.2 is basically where you cross over that threshold from risk of stroke to risk of bleed. And if you have a stroke risk of 2 or higher, the guidelines recommend that you take oral anticoagulation. If you have a score of 0, we used to say, well, you could put them on an aspirin. It makes us all sleep better at night, but we're really finding out that there's a lot of bleeding associated with that. And so a lot of the providers that I work with aren't even using aspirin. And then if it's a score of 1, then it's a shared decision-making discussion. You know, should we anticoagulate you? Are we going to try to cardiovert you? You know, those kinds of things, and just taking into the patient consideration. I have patients who say, I don't want to have a stroke, put me on it. I have other people who say, I don't care, you know, I don't want to fall and have a bleed, and they don't want to take it. So it's kind of managing patient expectations as well in that class 1. Along with the CHA2DS2-VASc score, we also look at their has-bled score. So we, you know, that is the CHA2DS2-VASc is the risk of, you know, embolism or stroke. And then we look at what is their potential risk of bleed. So the has-bled score accounts for, again, we're assigning points based on risk factors. Hypertension, if they have abnormal renal function or liver function, they can get 1 point for each. Have they had a stroke in the past? Do they have a bleeding tendency or predisposition? If they were on warfarin, do they have labile INR? So they're 5 one day and then 1 the next. Are they elderly? Which I take a little bit of offense to this as I get older, that they consider elderly over 65. And then drugs. So are they also taking NSAIDs, or do they have to take aspirin for some reason? And then there's the excessive alcohol, which I wonder what they consider excessive for this criteria. But essentially add up the points. If you have a has-bled score of 3 or greater, the guidelines recommend that you consider an alternative to oral anticoagulation. So in atrial fibrillation, we look at a CHA2DS2-VASc score to assess their risk of stroke. We look at their has-bled score to determine their risk of bleeding. And then we put those two together and jumble it up and then come up with a magic solution. Well, there's no magic solution. It's a lot of thought, talking with the patient, discussion, and those kinds of things. But we use these to help guide us. As far as what do we use to treat and prevent thromboembolism or clots from forming, we have vitamin K antagonists. VKA will be the abbreviation you'll see throughout the talk, which is essentially warfarin. Direct oral anticoagulants, and I highlighted this in red because essentially most of what we're doing, at least most in my world, and we're seeing lots of patients who are going to be on these direct oral anticoagulants. They used to be NOACs when they were novel, but now they're DOACs because they've been around for a bit. We can also use unfractionated heparin, which I'm not going to talk a lot about today. Low molecular weight heparins are injectables. Aspirin is not truly an anticoagulant, more antiplatelet, but it does come into play with other comorbid conditions. And then another strategy is using anticoagulation and antiplatelet inhibitors. And we'll talk a little bit about that, looking at the new guidelines that were put out for patients who have coronary disease or undergoing PCI who also require anticoagulation. And then we also have some non-pharmacologic approaches for management of stroke risk or thromboembolism with atrial fibrillation. And this is essentially managing the left atrial appendage, whether it's occluding it, excising it, or excluding it in surgery. And we'll get to that a little bit later. Anticoagulants have been around for a long time. Coumadin or warfarin was approved in 1954, and then we had nothing, right? So there's probably people in this audience who were once anticoagulation clinic nurses or nurse practitioners, or you run the clinic. There's pharmacists that may have done this. And then in 2010, dabigatran or dabigatran was approved. And that was sort of the new kid on the block. And that's when our paradigm with anticoagulation really started to change. Rivaroxaban followed shortly thereafter. Then we got apixaban in 2012. In 2015, the world was saved because Praxbind was approved. And so now we had an agent where we could reverse Pradaxa. We now also have agents that can reverse the 10A inhibitors. But that was a big change, right? Because everybody says, well, there's no antidote. Like if I was on Coumadin, I could go to the ER and get vitamin K. But if I'm on Pradaxa, what do I do? Now we don't worry as much about that anymore. 2015, Edoxaban. And then in 2017, Bextrixaban, and it was interesting, was approved, FDA approved. And this medication is no longer on the market. And I'll be 100% honest, as I was reading through literature and data on this, I was not familiar with this medication. This medication was indicated for prophylaxis in acutely ill patients who are hospitalized to prevent DVT or PE. It's interesting because it says it's no longer on the market. And if you look at why it's no longer on the market, it's due to manufacturing issues. And this made me think about, like, is this a supply chain issue, or was it a supply chain issue? And is it sitting out in the harbor of LA or Long Beach in one of those big containers just waiting to come? But I don't think so. I don't think we'll be seeing that anymore. So vitamin K antagonist, this is essentially Coumadin, warfarin, is going to inhibit the factors that are affected by vitamin K. So this is 7, 9, 10, and 2. Interferes with the hepatic synthesis of vitamin K. So 2, 7, 9, 10. Antidote is vitamin K. So remember, back in the day, if somebody was bleeding and their INR was 5, we'd be like, okay, we can give them vitamin K and that will reverse it. Therapeutic range, love it, hate it. That's where it is. For most indications, the range is 2 to 3. If you have a mechanical valve in the mitral position, then your target range is going to be 2.5 to 3.5 with a mid-range goal of 3. We all know the limitations of warfarin, narrow therapeutic range. So, how much time do our patients really spend within the therapeutic range? It has a slow onset of action. It has a slow offset of action, multiple drug interactions, dietary restrictions, and then there's frequent monitoring that's required, right? I know that when I was doing more anticoagulation management of warfarin, we used to check people frequently. Our anticoagulation pharmacists at UCSD, if patients have been stable, they're maybe checking once a month. But it does require monitoring, and people can now home monitor, but they used to have to come in or get a blood draw or finger stick, and it's really just plain inconvenient. So then on the market came the DOACs, and the first one was the direct thrombin inhibitor, which you can see here. It shockingly enough, inhibits thrombin, which is factor 2A, and that is Pradaxa. Now, these slides were made when these agents were relatively new. So I'm not going to speak to every point on these slides, but I didn't want to erase it because it was a lot of time and effort to put them together. So they're here for you as a resource. But essentially, Pradaxa is a direct thrombin inhibitor approved for stroke prevention in non-valvular AFib. And I'll just pause right at this moment to define non-valvular AFib. So the true definition of non-valvular AFib, valvular AFib, I guess, is what we need to define, is atrial fibrillation related to mitral stenosis. Severe mitral stenosis is what valvular atrial fibrillation is considered. So if they have any other valve issues and they have AFib, that truly doesn't meet the definition of what valvular AFib is. So Pradaxa, non-valvular atrial fibrillation, PE, DVT, post-op, it covers all of those indications. Normally it's 150 milligrams twice a day. Key points, increased risk of GI bleed in patients over 75. Patients can have a lot of dyspepsia on this medication, and it has to be stored in the original bottle. So if somebody's doing pill boxes for these patients, they can't take the Pradaxa or dabigatran out and put it in a pill box. The factor 10A inhibitor. So again, they're going to inhibit factor 10A in the chain here, which stops the formation of thrombin. The first one is rivaroxaban. Again, indications are the same as Pradaxa, so AFib, post-op, DVT, and PE. Dosages can be 10, 15, or 20 milligrams, depending on the indication. We do have an antidote to it now, Addexa. When we first got the antidote at UCSD, when we were talking about doing ablations and procedures, we used to have to be like, how many doses do we have in the hospital? And is it safe to do it? And who's going to keep it and whatever? And again, we're beyond those days, but it was a big issue when it first came out. Apixaban or Eliquis is another factor 10A, non-valvular atrial fibrillation, DVT, PE, post-op prophylaxis. Apixaban has kind of gotten touted because the data support that or suggest that it has a decreased risk of major bleeding, a decrease in intracranial bleed and GI bleed compared to warfarin. So our patients who we worry about having bleeding, a lot of times we will put on apixaban. Dosage is usually 5 milligrams twice a day, but we can decrease the dose if they meet 2 of the 3 criteria. And it's important because we have some people who are like, well, they look little and they're kind of old, so we're going to give them a reduced dose. And you really shouldn't just do that. You need to look at, are they 80 or greater years of age? Are they less than or equal to 60 kilos? And is their serum creatinine greater than 1.5? Again, we have an antidote for apixaban as well. And then there's edoxaban, another factor 10A, indicated for AFib, DVT, and PE. Usual dose is 60. Do not use if creatinine clearance is greater than 95, which is interesting. If they have a really high creatinine clearance, then we don't want to use this medication. Here's a nice summary slide that you can copy and paste and put somewhere or use it in a talk if you're giving, that just summarizes the different oral anticoagulants that we use and then what the indications are. So AFib, we can use all of them. Venous thromboembolism, we can use all of them. And if you'll notice on Pradaxa and edoxaban, there's bridging, and we'll talk about that in a minute. For post-op prophylaxis, everything but edoxaban. Warfarin gets a special nod, obviously, for treatment of mechanical heart valves. If your patient has a mechanical valve, they're going to be on warfarin, or if they have an LVAD, obviously they're using warfarin. As I was doing some research for this talk, I noticed that the cancer literature, which traditionally has used low molecular weight heparin to prevent venous thromboembolism in patients who have cancer or undergoing cancer treatment, apixaban has been shown to be effective. I read a couple of commentaries that were saying that it's going to be a huge paradigm shift for the oncology community to go to using something like apixaban as opposed to a low molecular weight heparin, but there is data to support that it can be effective. These are some nice pictorials just showing the indication for the drug and then the dosage that you're going to use. So for non-valvular AFib, again, 20 to 15 milligrams once daily with the evening meal. And apixaban is either 5 milligrams or twice a day, or 2.5 milligrams twice a day. If we're treating DVT or PE, then we're treating, okay, you get 15 milligrams twice daily for the first 3 weeks, and then they go down to 20 milligrams. So if you're prescribing this, or if you're dealing with patients who are on this regimen, it's super important to tell them that you're going from a twice a day lower size tablet to a once a day higher milligram tablet, and make sure that they're clear on that transition. So they're not taking too little or too much, depending on the circumstance. With apixaban, it's going to be 10 milligrams twice a day for 7 days. Then they go down to 5 milligrams twice a day. For treatment of DVT and PE, we don't recommend renal dosing adjustments. Again, non-valvular AFib with dabigatran, 150 milligrams twice a day is usually what is used. If we're going to use it to treat DVT or PE, they do have to have a low molecular weight heparin lead in. So it's not like we do both. We do one and then we do the other. So they get 5 to 10 days of the injection and then they'll take the pills. And then with edoxaban, it's generally 60 milligrams a day with a lead in with the injectable. And then they'll go to the standard dosing 60 milligrams daily. Laboratory monitoring, I'll be honest, and I don't know, I'd be interested to see what the participants today do, but we don't do a lot of monitoring of DOACs as far as checking levels or those kinds of things. We do CBCs. You can do a comprehensive metabolic panel or a basic metabolic panel, essentially looking at, are their blood counts okay? Is their renal function okay? But you can test. Obviously for the 10A inhibitors, we can check a factor 10A level. Like I said, I do not do a lot of that. I think it's done more on the inpatient side of thing at UCSD. If we're talking about dabigatran or dabigatran, you can check a PTT on that as well. Also noting that if these patients are taking these agents, that their PT is going to be elevated. It's not going to be within in a therapeutic range for warfarin, but we'll notice that the PT and the INR is elevated in these patients. And my understanding, and I'm sure our pharmacist colleagues could speak to this, I don't know that there's a direct, if it's higher for one or the other, but these are the ways that we can potentially monitor. When we're prescribing these medications or looking at the dosage, we want to make sure that we look at a variety of factors, which can include renal function, which I think we're all familiar with, hepatic function, body weight also should be taken into consideration, and then drug interactions. So I'm going to go quickly through these slides because we've kind of talked about these. These can be more for your reference, but essentially renal dosing with apixaban, you know, again, to meet criteria for the reduced dose, they have to be 80 or older, they have to be 60 kilos or less, and their creatinine has to be 1.5 or higher. It's not like, oh, they look little and old, so we're gonna do this. And I see that happen a ton. And then for rivaroxaban, again, if their creatinine clearance is 15 to 50, you're gonna use 15, otherwise you'll use 20. If it's less than 15, or if it's less than 30 for DVT or PE, they recommend warfarin, Pradaxa. I don't prescribe the 75 milligram twice a day. We usually would use a different agent, but you would reduce that. And then the edoxaban, remember, if they have a creatinine clearance greater than 95, you're not going to use it. If it's less than 15, you're going to use warfarin. And the same for DVT or PE. But again, just reference slides for you guys to take a look at. When we look at hepatic impairment, you know, I'll be honest, we don't see a lot of people in my outpatient setting who have, you know, terrible liver disease. We see a lot of congenital patients who will have, you know, Fontan liver situations and things like that, but they're not having elevated bilirubins or low albumins or tons of ascites. But looking at patients who do have hepatic impairment, you can use the Child-Pugh score to classify and then make a decision. So essentially, again, it's another looking at different various markers, bilirubin, albumin, ascites. You assign points accordingly, and then depending on the number of points they get, they either fall as a grade A, which is less than 7 points, which means that you can use whatever DOAC you'd like. If it's 7 to 9, that's B. Or 7 to 9 points, you get a grade of B, and then it's kind of used with caution. It doesn't say like what to do, but just be mindful. And then if they have 10 to 15 points, then there would be a Child-Pugh class C, and most of most of the dogs are contraindicated, other than rivaroxaban, which most of them are contraindicated if they're in C, and rivaroxaban is contraindicated in class B or C. And then we look at body weight. And this used to be a big thing when I worked at the VA. I have been gone from the VA now for about 4 years, but at the VA, the pharmacist there, when we were transitioning a lot of our patients off of warfarin onto DOACs, would say, well, did you look at the body weight? And, you know, if they have a low body weight, so normal body weight in the studies were 60 to 120 kilos. So that's really what they looked at. If your body weight is less than 60 kilos, then you dose adjust, and you would dose adjust either apixaban or edoxaban, and avoid using dabigatran or rivaroxaban. If they're normal body weight, you can do whatever you like. If they're severe obesity, or if they have a weight greater than 120 kilos, again, you need to consider that. You can have a person who's almost of normal body weight, like a bigger, let's say bigger man, for example, who's really tall or whatever it is, who can have a weight of greater than 120 kilos. And I wouldn't necessarily look at them and say, oh, they're severely obese. But the take-home message with this slide is that we don't have a lot of data that supports, in particularly, and again, our pharmacists could potentially, you know, clarify this, but for the severe obese patients. And so we're like, is it going to be effective for these people? We're not 100% sure, but we're going to be hopeful that it is. And then obviously drug interactions, right? So all medications have interactions with other medications, looking at the way that they're processed through the liver. So all of the DOACs are substrates for the P-glycoprotein, which helps to clear medications. Rivaroxaban and apixaban have a significant, or they have interaction in the CYP3A4 metabolism. So drug interactions that are commonly, that we commonly see with these agents can be anticonvulsants, antiretroviral agents, antifungal agents, and then obviously other antiplatelet agents because they increase the risk of bleed, and non-steroidals. So we want to be taking a look at what other medications are these patients taking. Most of the time, these patients will be anticoagulated, and then we're thinking about adding something in, and we need to think of like, is this okay to add this other agent in? What is it going to do to our anticoagulant? All right, and then I termed the next portion of the talk, special considerations. And if this was like my daughter's room with stuff all over the place, that would be what this talk is about. Because I'm just going to kind of cover a bunch of different topics that I thought are important when we're talking about anticoagulation, of things that we should consider or things that come up as questions frequently. This was mentioned in the other talks. Medications are expensive. These new medications are on patent. You know, these companies have spent tons of money in research and development, and they're expensive, and you know, a lot of people can't afford them. So I went to GoodRx, and so I didn't do a super deep dive, just to say, if I went to GoodRx and I looked at these different medications, how much would they cost me per month? So warfarin, it says I could get for $16 a month. This is no insurance. This is me walking in with a prescription and buying it. Eliquis is about $518, Xarelto $511, and Pradaxa $495 per month. So that's expensive, particularly for our elder patients who are on fixed budgets. This can be cost prohibitive. It can result in patients, which I've seen, taking one tablet a day, cutting it in half. Maybe I skip it on Sunday or whatever it is to stretch out the prescription, and then clearly they're not protected. Affordability may be low. There are patient assistance programs you can fill out, do the prior auths and those kinds of things to get them covered. They have patient savings card, like for patients who maybe need a month, you know, you can get a month free, you can get a month for $10, or the copay cards. Samples don't exist at UCSD. I don't honestly know if they exist anywhere, but I remember there was a time at one point where you could get samples. We had a patient who is going to undergo a procedure where he's going to need 45 days of apixaban, and we've been trying, and I just talked to everybody that I know. Does anybody have samples, just to see? And they're not available. Some of the assistance programs can be labor intensive, filling out the paperwork. We have patients who are on a patient assistance where the medication gets mailed to the clinic. Then at UCSD, the policy is the clinic takes it to the pharmacy, then the pharmacy relabels it and dispenses it. So it's a whole process. But if that's the only way you can get your patients on these medications, we need to work with them and try to be advocates for them. It's because it's an arduous process and it's not easy. Transitioning, right? This is something that comes up all of the time. I want to start this, or I want to start that, or I don't want to take this, or that I can't afford, you know, apixaban anymore. I need to go to warfarin. For the DOACs, it's pretty straightforward. On the right hand of the screen, essentially, you're going to go from one to the other. So when the next dose is due, you're going to start the new medication. We don't recommend overlapping the medications, and we don't recommend skipping any doses. So essentially, you just take one, and then you start the next one, whatever the new one is going to be at the next dose. When we're going from warfarin to a DOAC or DOAC to a warfarin, then it becomes more complicated. So if you look at the green here, this is our vitamin K or warfarin. So we're going to stop it. We're going to wait till the INR is less than 2 if we're starting all agents except for rivaroxaban. If with rivaroxaban, you can start rivaroxaban if the INR is less than 3. So either INR of less than 2 or INR of less than 3, and then you start the new agent. And remember, because they have a quick onset, they're going to just be up and running and you're not going to have any trouble. So going from warfarin to a DOAC is relatively easy. You have to be monitored, and some places do it different than others. Check an INR after 2 days or 3 days, and it just was probably facility dependent. If they are going from a DOAC to warfarin, then it becomes a little bit trickier. So you can either overlap them by a couple days and check the INR, and once the INR is up to speed, whatever you decide that is, then you can go ahead and stop it. Or you can also bridge with that terrible term bridging that used to be a very commonplace in our practice, with low molecular weight heparin. So go from the DOAC, stop it, start low molecular weight heparin, start warfarin, and then stop the low molecular weight heparin when you're up to speed. All right. So the next topic, again, remember, these are kind of like quick hitters all over the place. Anticoagulation for cardioversion. So let's say you're working in the emergency department, or you're in cardiology clinic and your patient calls and says, I'm in atrial fibrillation. You're like, okay, well, do you need to go to the ER? Are you stable? And we're like, yes, they're stable. So then you're like, okay, are they on an anticoagulant? So we sort that out. If they have stable atrial fibrillation and it's been going on for greater than 48 hours, and the 48 hours discussion could be a whole other talk in and of itself, because at different institutions, they use different things, but basically they're stable. You know, you want to try to get them back in normal rhythm because they don't feel great. So what are we going to do? We're going to have them get therapeutic warfarin levels, so INR greater than 2 for 3 consecutive weeks, or make sure that they're taking their DOAC and haven't missed any doses for at least 3 weeks. So this becomes the honor system, you know, and I tell my patients, have you missed any doses? No. Are you sure? Because if you have missed doses, then you could be potentially at risk of stroke. And we don't know for sure. Sorry about that. It's my work computer trying to connect to the VPN. We don't know for sure, so we kind of put the onus on them. With warfarin, I don't know if you guys remember, you know, 3 weeks in a row, and then we'll schedule your cardioversion. 2.1 is the INR, 2.3 is the INR, and that is 1.7. And then we're back to square one. So it's really nice. We just say to the patients, don't miss any doses and hope that they don't, and do the cardioversion. Afterwards, we're conservative, and recommendations are that you continue warfarin or continue the DOAC for 4 hours or 4 weeks rather afterwards. They show up in the emergency department and they're unstable and they're not anticoagulated and you need to do a cardioversion, you could potentially give them unfractionated heparin, so start them on a heparin drip or low molecular weight heparin. We're in a facility where we readily available can do a TEE, so it's usually they'll just do a TEE and not do anything necessarily ahead of time. If there's no clot in the left atrial appendage, they'll proceed with the cardioversion and then anticoagulate them for a month afterwards. If there is a clot, then obviously you're not going to shock them and potentially send the clot on its way. So then we have to make sure that they start anticoagulation, that they do that for 3 or 4 weeks. They're checking INRs or making sure they don't miss any doses. Then we repeat a TEE to make sure that the thrombus isn't there, and then consider cardioversion. I will tell you, there are practices in the community where I live where people will go in and say, I've been in AFib for 12 hours, and they cardiovert them and they send them out with nothing. And that sort of makes me go, but it happens. So I don't know what happens in your facilities, but these are what the guidelines would recommend and support. But I see it happen in all different ways at other places. All right, well, we're on the subject of atrial fibrillation. I wanted to just kind of pause, even though this is a little bit off topic, but talking about non-pharmacologic management of stroke associated with atrial fibrillation. And this is essentially managing the left atrial appendage, because if you remember back to the beginning slides, we think that most stroke associated with atrial fibrillation comes from clot in the left atrial appendage. So as you all know, the left atrial appendage is a little sac-like structure off of the left atrium, and blood gets stuck in there, and then the clot gets out and goes to the head and causes a stroke. So what can we do? We can occlude it. And these are a variety of different ways that we can do that. So these are percutaneous over here. This is our surgical approach over here. So this top picture here, which I'm circling, if you guys can see that, this is the Watchman device, which has been FDA approved for several years. The Watchman, when I explain it to my patients, say it kind of looks like the top of a parachute. I think of it as sort of like an old school bathtub plug, like we just go in the left atrial appendage and we just stop it up. So it's delivered into the left atrial appendage through a catheter that goes across the septum. Everything comes out except the device. When they get a Watchman device, they have to have a CHADS score of 2 or a CHADS VASC of 3 to qualify, and then they have to have some condition that they shouldn't or couldn't or can't take anticoagulation. They do require 45 days of oral anticoagulation afterwards. Usually we'll use a DOAC plus aspirin. Then they come back at 45 days. We do a TEE to make sure everything's healing. Then they move to, usually it's Plavix and aspirin. And then at 6 months after implant, they're just on aspirin. But they do have to have that anticoagulation for 45 days. This next device over here is actually an Amplatzer device, but this has been sort of tweaked a little bit to what was recently FDA approved, which is called the Amulet device. We are working on getting Amulet at UC San Diego. We do not have it yet. This is essentially another sort of plug, if you will, to basically block off the left atrial appendage. The nice thing about Amulet is that it's not anticoagulation. It actually requires just dual antiplatelet therapy, which is good for our patients who we really worry about bleeding on anticoagulation, even if it's just for a short period of time. And then this little picture down here is what a lariat is. And essentially a lariat, I think of it as just like a lasso, right? So you go in, you get access to, this is to the epicardial space, you're gonna lasso that left atrial appendage. And essentially, if you can see here, kind of basically snip it off to the point where it just sort of shrivels down. As you can imagine, and it's happened, and knock on wood, I hate to say this, but I've been in facilities where this has happened, they can lasso off the appendage. So instead of just crimping it down and really, they can actually take the whole thing off. And then if you're doing this in an EP lab or procedure area, not during an open chest, you've got bleeding out of the left atrium, and that can result in them having to open the chest, so it can be a thing. But that is the Lariat device. As far as I'm moving you guys around. The epicardial occlusion techniques, these are surgical techniques. So this is just a pictorial. This comes off of the slides from the LAUS 3 trial, which was presented at ACC this year. Left atrial appendage, you can staple it shut, you can amputate it, you can use an AtriClip, which is very common, and then you can also suture it off. So these are other ways to remove the left atrial appendage or to exclude the left atrial appendage in surgery, so a surgical option. Okay, so these are percutaneous options, these are surgical options, Watchman, amulet, Lariat, and then these are the surgery procedures. Speaking of the surgery procedures, like I said, presented at ACC this year was the LAUS 3 trial. And essentially what they looked at in LAUS 3 was, so patients who have atrial fibrillation who are going for surgery, so a cardiac surgery, so they need a valve, they need whatever it is, should we take off their appendage or should we not? And essentially what they looked at was stroke risk associated. Did it decrease the stroke risk? It wasn't like we're going to take off the appendage and stop anticoagulation. All they simply did is they said all patients coming for surgery, cardiac surgery, who have atrial fibrillation, they were randomized to either taking off the appendage in one of those ways, so a clip, excising it, whatever it was, or they left it there. And what they found and what they presented this year when they reported the data on the LAUS 3 trial is that patients have less stroke if their appendage is not there, if it's taken off. So they do better as far as stroke risk goes. Now, the important thing is, and I say this to my attending, well, why didn't they look at stopping anticoagulation? Because isn't that the $1 million question? But they didn't, and we don't have that data. So when you have your patients who said, well, I just had valve surgery and they took off my appendage, do I need to be on anticoagulation? And then we're like, oh, well, let's get a TEE and look and see, do you have clot there, whatever. So lots of discussion here, but essentially what they showed is that if I'm having cardiac surgery and I have atrial fibrillation, if they exclude or excise my appendage, I'm going to have less risk of stroke. Okay, I'm going to hit these really quick in the interest of time and getting us all onto our Saturday, because I think we know this stuff. If you get a mechanical valve, if you have surgery and you get a mechanical valve, you need warfarin. For the bioprosthetic valves, it becomes a little bit different. So we're going to look at if you had mitral valve repair, and again, I will say this, in different facilities, it's different, right? So if you talk to people who work in different areas, then you're probably not going to, you'll get different answers. So with bioprosthetic valves, so mitral valve repair, 3 months of vitamin K antagonist, which remember is warfarin with an INR of 2.3. If you had mitral valve repair with a ring and you're in sinus rhythm, they recommend 3 months of antiplatelet therapy over using warfarin. So antiplatelet. So to make it simple for me today, I'm calling like this is Plavix. After 3 months, we would recommend maybe taking an aspirin daily over no aspirin. If they get an aortic valve replacement and they're in sinus rhythm, they get 3 months of aspirin, 50 to 100 milligrams, preferred over using warfarin. And if they have an aortic valve repair, remember this is surgically, they're going to take aspirin over warfarin again. And so these are what the recommendations are. Like I said, I talked to some of my friends who work in surgery, and they have different providers within UCSD that do things differently. So, so you have to look at your facility and what the people you're working with, the surgeons you're working with do, and obviously you're going to go by their lead. When we look at anticoagulation for patients who are undergoing percutaneous heart valve replacement or repair, I initially had this screen set up so that it would be a comparison of aortic valve replacement, TAVR or TAVI, versus mitral valve repair, which is mitral clip, and what do we do? But as I talked to my interventional colleagues and our structural heart team, the people who are doing the bulk of this, my understanding, and I know there's people in the audience who could speak to this better than I can, is that there's no large clinical trials. There's no data that says this is exactly what you have to do and this is what the recommendation is. We know kind of what we should do or what people do, but there's no like guideline that says we looked at X number of patients and this is what we're recommending. So these are some ideas. So when we're looking at patients who are having a TAVR or TAVI or mitral valve or mitral clip, is there a current indication for therapeutic anticoagulation? So do they have a DVT or PE? Do they have atrial fibrillation? If they do, then we're going to look at, do they also need an antiplatelet? So now I need, and just for ease, I'm going to say apixaban so I can keep it straight in my head. And now they need an antiplatelet agent, Plavix. Then, so if the answer to that is yes, you're going to get antiplatelet therapy plus anticoagulation. Okay, if the answer that they don't need antiplatelet therapy, then you're just going to do therapeutic anticoagulation. So that would be continuing apixaban. Do they have therapy, an indication for therapeutic anticoagulation? They have AFib, they have a DVT or PE. If the answer is no, do they have an indication for dual antiplatelet therapy? If the answer is yes, then you go with dual antiplatelet therapy. If the answer is no, then you go with SAPT or single antiplatelet therapy. Okay, and then so I talked to my people at UCSD, and this is almost a quote from one of our interventional fellows who I love. She's wonderful. She says that for our mitral clips and our TAVRs, if the patients are not high risk for bleeding, so again, this is our assessment, not a tool that's been standardized, but if we say they're not high risk for bleeding, so they haven't had a massive GI bleed or whatever it is, and they're not on anticoagulation, so they don't have an indication for a DOAC or warfarin, we do 3 months of Plavix and aspirin, and then they do aspirin indefinitely. For TAVRs with a high risk of bleed, we're going to do aspirin therapy indefinitely. If they're on anticoagulation for another indication, then they get an aspirin and anticoagulation indefinitely. And like I said before, poor aspirin is really falling out of favor. We're not using it a lot, but this is what the recommendation, I won't say the recommendation, this is the practice at UCSD. This is what we do. And I'm sure if we talk to the 43 people who are participating right now, we would get different answers of what they do as well. And I know I'm not sure I forgot to start my timer, which is a problem, but I'm sure we're getting low on time. But the next thing is oral anticoagulation and antiplatelet agents in patients who are undergoing PCI or who have atherosclerotic cardiovascular disease. So this is the 2020 ACC expert consensus that was published in JACC in February of 2021, looking at what do we do, because we all know whether you work in an interventional team or you work on an EP team or whatever it is, we're constantly being faced with patients who have indications for multiple agents. And how do we manage this? And how do we make sense of it? And again, the guidelines are guidelines, and we know that some of our people do what they're going to do as far as what they recommend and what they prescribe. So I just hit key points. For atrial fibrillation, so these are patients who have atrial fibrillation who either need a percutaneous coronary intervention or a PCI, or they have a coronary artery disease. Triple therapy is not recommended in most patients due to risk. So what is triple therapy? So it's dual antiplatelet therapy, which is DAPT, plus OAC, which is oral anticoagulation. So this is my patient who has atrial fibrillation, comes in with a STEMI, goes to the lab and needs a stent. And then they're on apixaban, and then we're going to put them on, like I said, clopidogrel, and then also aspirin. So you possibly would do triple therapy for the first month. So aspirin, Plavix, and apixaban, and then get rid of the aspirin. So then the aspirin goes by the wayside. When we're combined with oral anticoagulation, clopidogrel is the preferred antiplatelet agent. So if they have to be on apixaban, we prefer, or the guidelines recommend clopidogrel. Aspirin, if we're going to use aspirin, should be less than 100 milligrams, okay? We should consider putting these patients on PPIs, all right? I know that, sometimes we're hit or miss with this, but they should. If they're on 2 agents or more, we want to consider putting them on a PPI to a proton pump inhibitor like Prilosec or whatever it is to decrease the risk of having a GI bleed. If PCI is needed, so they need an intervention, we would rather they be on a DOAC, so like apixaban over warfarin. If they're going to be on oral anticoagulation plus a 2pY12 inhibitor, then they would take that for 6 to 12 months, then consider switching to aspirin. So this is oral anticoagulation plus the P2Y12 for 6 months, then for 6 to 12 months, then considering switching to aspirin. So maybe you do 6 months of this, then you do 6 months of anticoagulation and aspirin. And then after that, they would go to monotherapy with oral anticoagulation. So again, you know, not trying to minimize the number of patients who are taking more than one agent. And depending on their anatomy and their history and their story, maybe they can just get away with oral anticoagulation. Maybe even though we've been drilled into our head forever that these patients need antiplatelet agents, maybe they don't. Couple things, you can use standard dose, but if per the Pioneer AF study, you could use rivaroxaban at 15 milligrams as opposed to 20. If our patients have a venothromboembolism, and so let's just say that they are patients on antiplatelet therapy who develop a PE or a DVT. If they were on antiplatelet therapy for primary prevention, so this is a patient, let's say, who's diabetic, who's never had an event, who is taking aspirin for prevention, then you would stop that and start anticoagulation. If they need to have an intervention, then you're going to go to dual therapy. If we can delay doing an intervention while they're on, let's say that they have a DVT and they needed to take whatever it was for 6 months and then they're going to stop it, can we delay our PCI until month 7? If they're going to need long-term anticoagulation for recurrent DVT or PE, then we follow the same guidelines as AFib. And then we should hold the DOAC for 36 to 48 hours prior to the PCI if we can get away with it. And we may need to adjust based on renal function. And this is, oh, what happened? Okay, so a quick case study of somebody who recently came in, 58-year-old male, suffered his first STEMI 1 month ago. He got a PCI to his RCA, so he got a stent to his right coronary artery, bare metal stent. Now, my colleague gave me this case study. So when I said bare metal, when she said bare metal stent, my first thought was, okay, why did we give a bare metal stent? But he was started on aspirin and ticagrelor. And then we do an echo and he has an LV thrombus. So now he's on Coumadin as well. So this is a man who, because I know the backstory, came in on 0 medications, come to our county hospital. It has minimal insurance coverage and is now on aspirin and ticagrelor and on Coumadin. And not only that, but now he needs a staged PCI to his LAD. And we're going to bring him back in a couple of weeks to do that. So he went from aspirin and ticagrelor. They gave him Lovenox to bridge him to his therapeutic Coumadin. Then what's going to happen with him is he's going to come in for his procedure. They're going to take him off Coumadin, bridge him with Lovenox, and then do the aspirin and ticagrelor. And then the plan is once he's a month after the LAD stent, then he's going to go off of aspirin, take ticagrelor and Coumadin. So this is like an anticoagulation nightmare, going from a man who's at 0 to needing all of these agents.
We have 2 minutes.
Yep, and this is probably a talk in and of itself. So I'm just going to go through this super quick. Interruption of anticoagulation, do we do it or do we not? I don't know how many of you manage people who are on anticoagulation, but I probably get at least 2 or 3 of these requests a day. Can Mr. or Mrs. Y stop anticoagulation for said surgery? So when we look at that, we need to look at what is the thromboembolic risk of the patient, what is the bleeding risk of the surgery, and do we need to bridge them? I will say that with the coming about of DOACs, we don't bridge a lot anymore, which is wonderful. But if there are certain circumstances where we do. So I'm just going to go through these real quick. You guys can read. We look at the risk of thromboembolism, high, moderate, or low, depending on their various indication and needs. So if they had a stroke, do they have a mechanical valve, et cetera? What is the bleeding risk? When I was reviewing for this talk, a lot of the thoracic surgery and the chest data was saying that we sometimes overestimate the risk of clot formation and tend to start anticoagulation too soon. But we look at bleeding risk and then we make a decision. If they're on a DOAC, can we hold off? What is the risk? Can we wait longer to eliminate it? When do we restart? And you guys can read this as well. This is a very large chart that talks about where their renal function is and when to hold before procedures. I don't know about you guys, but in my practice, it's usually like stop 48 hours before, unless they have renal insufficiency that I know of, and then resume as soon as safe to do so, usually within 24 to 48 hours, depending. But this is a whole breakdown based on their creatinine clearance with the different agents of when to stop them and potentially when to restart. If it's a low risk procedure, restart at 24 hours. If it's a high bleeding risk procedure, start at 48 to 72 hours, okay? This is looking at patients undergoing surgery, non-cardiac procedures who have mechanical valves. So this is still where we might need some bridging. You can look at the bleed map score, and this is a nice table here that sort of breaks patients up into low bleed, low thromboembolic risk. So the surgery is low risk of bleeding, the patient is at low thromboembolic risk, and you could continue Coumadin or warfarin throughout if they're at moderate to high risk or low thrombotic risk. So this is all in your chart. But essentially, this is saying, when do we stop? When do we bridge with low molecular weight heparin? Like I said, with and this really comes into play in patients who really have heart valves, and specifically mechanical heart valves is where we think more along these lines of really having to bridge. With the DOACs, I would be curious to know if anybody does bridge. We do not. We stop it. We're like, if they have to have it done, they have to have it done. Unless they've had a recent stroke or TIA, we tell them that or a procedure that requires anticoagulation, we tell them to go ahead. Obviously, if it's urgent or emergent, then they need to do what they need to do. But in elective procedures, we usually will just stop the DOAC and then tell them to resume as soon as safe. There's another case study which you guys can look at. There's an app online called MAP, which basically you put in what anticoagulant they're on and what the situation is, and it will give you to the guidelines. It's all the guidelines, so it's not like bullet points of what to do. And I will end there. That is my daughter, Rory. She is at University of Washington. So I was excited to see that Jocelyn went there. And that is a picture of us. And if you have questions, there's my email. Please feel free to reach out.
Great. Thank you, Stephanie. Wanted to turn to Michelle or Liana. Any questions?
We do not have any questions in the chat, but Randy did post in the chat that her group likes to use the ACC Manage Anticoag app to determine interruption or bridging. And so I just wanted to highlight that to the group as a really excellent resource.
Perfect.
All right. Thank you, Michelle. So Stephanie, definitely, you really did tell me that to keep my fishing hooks on. I did. I tried to get several rods as much as I can, and the hooks multiplied it. I mean, as to the listeners, like, this is a vast topic. Again, it goes to the W's that we could employ. I mean, every single patient gonna get back to the drawing board. Yes, no, who, where, whether or not. Always these matching games, because at the end of the day, is this patient the risk of forming clot, and does the patient have the right agent in the right amount and the right choice? So use the tools that, Stephanie, thank you for this tremendous experience that you carry and you shared with all of us. This is so valuable. I recommend, reference all the slides that you shared with us, because so much goes into it. There's not one slide you can pick out because one is dependent on the other. So the important tools that you mentioned about the child vasculars, which you're familiar with, has bled score, and then the Child-Pugh score, and then transitioning from one anticoagulant to the other or in between. So those things are important. And the one is for the patients, no pill box when you're going to use diazoxide. And is that correct, Stephanie? Did I get that right?
Yes, you did.
Correct. And then in terms of monitoring, as Stephanie mentioned, because sometimes you work with the local surgeons, the local hospital, look at what the diagnostic monitoring is needed for these agents so that they could, follow the local policies and including the guidelines. So with that, we're going to thank you so much again, Stephanie. And we're going to transition into QA, and we're going to announce the prizes, the closing prizes. I'm going to have Mary share her thoughts as well before we go to QA. And I also want to mention about Zol. Zol, thank you for sponsoring this event. And before we go to Q&A, Mary, you want to take here? And then I'll come back for the announcement of the prize draw. Oh, you're muted.
Is everyone's dream come true? I just want to thank everyone for taking the time this morning on a Saturday morning and joining us. I know the committee took their time in planning this. And I think I want to thank our speakers for doing such a wonderful job. This is a symposium for the cardiovascular team members. And I want to stop and acknowledge that we had nurse practitioners, we had PAs and pharmacists. This is truly a cardiovascular team presenting, and such excellent speakers. So I want to take a moment to thank Viet, Stephanie, Kathy, and Jennifer. So wonderful speakers for all. And I think, Jonathan, we're going to talk about the link and the post-test, and Jonathan's going to announce our prize winners. And
Yes.
Thanks, Jocelyn.
Thank you. Thanks, Jocelyn. And thank you, Mary. So let's do the drum roll. I don't know, there's a ritual drum roll. Let's do that. And so so I'm going to read what I have here. So the prizes are set for 2 beautiful California ACC stadium seats and blankets. The 2 winners of the said seats are Teresa Brown, clap for Teresa Brown, and Felice Garcia Banach. I'm sorry if I did not say your name correctly. My apologies to you. All right. All right, we will ship this Monday. Please have your address entered in chat. You could address it to Liana so that you could have this shipment reach you safely. So once again, congratulations to the winners, and congratulations to great learning that we had today, and to the presenters. Immensely thank for what you have, all your efforts in putting this through. Over to Michelle and Mary for Q&A.
Do any of the participants have any questions? You want to put it in the chat box and Michelle could read off?
No questions at this time, just Felice and Teresa being very excited about being our prize winners for today. Congratulations.
I have a question for Kathy. Kathy, I know some of these drugs are pretty difficult in terms of getting authorizations. Do you have someone in your practice that actually works on these ahead of time? How does that work out for you?
Yeah, it's a great question. Virtually all of the medications require insurance authorization. And when I first joined the group in 2011, the APMs were getting the authorization. So we've moved a long way. We now have a pharmacist and a pharmacy team and an LVN that helps us with the referrals. But I have to say, it's our pharmacy team. It used to take like a week to get certain medicines approved. Now it takes like 24 hours, to the point where we're having trouble keeping up with it. But I think when these meds are prescribed, we just have to be very clear in our documentation. That's what it comes down to, really showing that they meet the criteria for that WHO Group 1 PAH.
And what's the time frame does that usually take?
With our team is just expert. Most of the time, it takes about 24 to 48 hours. But for other practices, it takes, 5 to 10 business days.
Okay.
For prostacyclins, it can take a little bit longer because you're not just getting medication, you're getting the pumps and the supplies as well, and the associated nursing care in the field. And then finally, it also depends on what type of insurance you have. And a lot of the patients with managed care, we have to jump through a lot of hoops.
Same question for Jocelyn, because, I remember trying to get Entresto when it first, and then some of the newer ones now, and time frame, and who does that for your team?
So we have, the nice thing about Entresto is all the robust literature that has been recently published with it. And the FDA actually approved its use for HFpEF patients recently. So if you look at the labeling, it's not only for our HFrEF patients. So having that in there is really helpful when we're completing these prior authorizations. We do have assistants in our outpatient pharmacy at Cedars-Sinai, designated prior authorization tech who can submit all of this information. We usually use covermymeds.com. I think most insurance plans use that system, and essentially we get a 24-hour turnaround too, if not same day, for this medication.
Thanks. And Jocelyn, it looks like there's a question in the chat directed towards you. With the, oh gosh, I'm not going to be able to pronounce it. Vasoreactivity?
Yeah,
I had a patient who we were restarting in the hospital setting and had a plan to increase the dosing based on his trial prescription. Is there any consideration when not being able to increase the dose when considering a patient may not tolerate the medication, or is there a minimal dose accepted that is considered beneficial to the patient?
That's a really good question. Vasoreactivity, you know, I haven't seen a lot in clinical practice just because of how recently it was approved and available on the market. But I mean, it's great that the patient was able to actually obtain the medication first. And essentially, as with all heart failure GDMT, you know, we just want to try to get the patient to the maximally tolerated medication. Of course, we're not going to force, you know, high doses on patients where they're passing out. But I would essentially evaluate their heart failure regimen and see what doses they're on for, you know, the 4 pillars of GDMT that we had talked about, to make sure they're optimized in that aspect. Because, you know, if they're on low doses of everything, you know, maybe you would want to spend your blood pressure room on optimizing on the getting to target doses for your ARNI beta blocker, spironolactone, and your SGLT2 inhibitor, versus trying to, you know, spend a little bit of blood pressure room on a really expensive medication. But yeah, is how I would approach it.
I have a question for Stephanie. Stephanie, have you tried one of the NOAC reversal agents yet? And what has your experience been with?
Personally, no. I know that we have had to unfortunately use it in our lab at times. So I don't have any personal experience with using either Praxbind or with Endexa. I do not. But I know our lab has been able to do it, and they've had, it's really actually, like I said, the first time it was like a major crisis. Everybody's running around freaking out, but now they've used it a couple times and feel a little bit more comfortable. Pharmacy knows where it is. We know where the doses are in the hospital, so it's not as big of a problem.
Yes, I know my doctor is quite reassured knowing there's a reversal agent. Does anyone have any other questions? If there are no other questions, I think we could wrap it up. I want to thank everyone for spending time with us on this lovely Saturday. And Leanna, I think Leanna is going to send out links for everyone for the evaluation, correct?
Yes, that's correct.
Thank you, everyone.
All right. Thank you for coming, everyone.
Bye. Thank you.
Thank you.